Okay, so good morning again to all our speakers, lecturers, and fellow colleagues. So our topic of CME today is critical thinking and reasoning. So it's a very important skills in emergency department to strengthen us as emergency physician. Today we have 4 esteemed speakers who will be joining us to share with us their ideas, thoughts, knowledge, and their experience throughout their journey in emergency physician. As an emergency physician, we appreciate the time allocated and spent for us in this current pandemic situation. We will start off with a video first, then we will go into our first speakers. Okay, so our first speaker is Associate Professor Dr. Sheikh. He's a senior consultant emergency physician and senior lecturer in University Science Malaysia, USM. He's also currently President of College of Emergency Physician Malaysia. His special interest is in emergency ultrasound and also critical care and wilderness medicine. Without much ado, let's start our CME with a short video, and then we will proceed with our first topic by Associate Prof. Sheikh, thinking like an emergency physician.
Apa, dia kena Syed Muhammad je. Okay, Assalamualaikum warahmatullahi wabarakatuh and a very good morning. First of all, thank for the ED HUKM for inviting us, myself and Prof. Shari to be with you guys today. So I hope today's is more like a sharing. It's not a lecture of how to become a leader. Like it's more like a sharing how you can become a leader with what's been given to you so far. You guys should know why you are here now as an emergency physician to be. So just to emphasize, some of the topics that I've been presenting today is not from any books. It's more like from many experiences I've gone through. I'm not that senior enough to say that because I'm still young compared to Dr. Ida and Dr. Surya. I'm the batch which is first conjoined batch together with Dr. Ida, Dr. Surya, Dr. Khaldun. We all are from the same batch, the first conjoined batch. So that's why we are very close among our side from that batch. So today I'll be sharing to you guys about how is thinking like an emergency physician and what things needed to be a good emergency physician. Sorry if this lecture is not going to give any additional points or hints for your coming exam. There is no such hints in this lecture because I know all the time when we become master students, we want to have hints for exam, especially when the exam is another 2 more months away. Unfortunately, this lecture we're not giving you any hints. It's just like sharing how to become a good EP. The effective practice of medicine requires an approach, a way of thinking that differs from other medical specialties. I think everyone knows why you are here in this program, because we are not like other medical specialties. We don't behave like them. We don't think like that. And it's a complex activity because we, like a circus performers, always have to spin stacks and place on top of another and different shapes and weight. We always juggle with everything. Okay. So I think this is a very nice quote. When you are managing an emergency department, you are trying to keep everybody calm. So when an emergency comes in the door, everything can do their best work. That is our task, because people always say emergency is like havoc, madhouse. Let people say that. But I think what we need to do in an emergency department, as an emergency to be, you keep the department calm and you rock when things comes in. So what are the issues in the emergency department? I think we have gone through this many times. High decision density. You need to act fast. You need to act accurately to decide on things. Decision fatigue. If you've been working on the floor for 8 hours, non-stop seeing patient, there will be decision fatigue. You cannot deny that. Even how good you are, you're going to have some kind of fatigue at the end of the shift. And we are the only department looking at the wide range of illnesses. It's as simple as a simple green zone cases that not even shouldn't be there until the patient who collapse. So we are looking at this whole range of illnesses. We are dealing with diagnostic uncertainty. We are the only department dealing with patients without knowing what is their diagnosis. We are basically treating the symptoms, treating their presenting complaints, and we never bothered about diagnostic. Having a diagnosis is a bonus for emergency department. And we have a very narrow time window. We have no ample time to take all the investigation and wait for the results and say, okay, this is the diagnosis. No, we don't have the time. We have shift work, we have sleep disruption. I don't know about during the younger age, it's not as what I am now. If I stay back up to 2 or 3 o'clock in the morning, the sleep disruption really cost me another 1 or 2 more days to recover myself. So that is how much the judgment is being challenged when you have sleep disruptions. And we are the one who only have shift changes. When shift changes, I know a lot of things happening. And that's not taking into account regarding the access block during disaster and currently with the pandemic. And these are all the issues that we are looking at every day in and out. So mostly it's not what we don't know, it's how we think. So this guy, Pat Crosscurry, is a critical thinking program director from one of the university. So I like to hear his talk. So the way he put up the things, he knows in emergency department, most of the time, we don't know a lot of diagnoses. They are very uncommon presentation of the common diseases and common presentation of uncommon diseases. We do not know everything, but we know how to think to manage the patient at the point of time. We know how to think where the patient should go. We know how to think what the next move for this patient and how they're going to cater this patient for the next best management. And of course, we do not know everything about the disease. Because I'm emergency medicine specialist, because we are freaking awesome. Okay, it's not an official job title, but we are freaking awesome. Despite whatever people say regarding our emergency medicine specialists, we are good. We are really good. But sometimes it's very difficult for other specialties to agree and approve on that. So do not be down because of that. We are good. Okay, let's see a case scenario. This is the common case that usually we see. A 56-year-old presented with left-sided chest pain for 2 hours associated with shortness of breath, nausea, and vomiting. No previous medical illness before. So what do you guys think patient might have? So you can give the whole list. I give you this algorithm. So this is how the emergency department chest pain evaluation pathway. So you can go through the boxes. You can go through the algorithm. You can go through the flow. I'm here today not to discuss about the flow. I'm here today not to discuss about the checkbox that you have to tick for every patient came into the department. I think you guys are very well versed on that. I think those lecturers in UKM, lecturers in USM, lecturers in UM, everybody teaching the candidates to become a good emergency physician on the basis of knowledge and skill together to treat any problem came into our department. I think we are doing that. I think you guys are good in this thing. I'm not here to teach about how to look at the algorithm. Example of this case, 40-year-old diabetes mellitus, fever, and possible infection, plus hypotension. What comes into your mind? Septic shock, sepsis plus. It's straightforward, it's simple, because looking at the symptoms and the problem, you know what is that. So actually, you do not need to think, you just remember. This is the Bloom taxonomy. You are looking at this lowest part of the thing because this is your experience space. By looking at it, we say it's a what we call pattern recognition. So when you see that, you know this is this. Okay, there's nothing to analyze, nothing to evaluate, nothing to create. You know by looking at this, this is the diagnosis. Then you manage the patient according to it. So this is why we have 2 theories. I'm not going to dwell in detail on these theories, the DPT theories, dual process theory, because I believe Prof. Ashari going to be in detail on this thing on the next lecture. So I'm just going to just brief through. So type 1 is more on intuition. What do you immediately come into your mind when you see a patient? Unconsciously making a decision, and it's pattern recognition. If type 2 is a bit more analytic and more logical based, you will have to deliberately, carefully all the features of symptom and signs, and you have to put a bit of more effort to get the diagnosis. So there are two different type of thinking process going on. So these are the few things that there, but I think Prof. Ashari will be dwelling more into this. Okay, so intuition is, I'm just going to circle two things. The butterflies in your belly, the gut feelings. I think most of you have got this whenever you manage the patient, right? So it's more like a war in between your brain and your heart. What your brain thinks and what your heart thinks. So this is it's more like a dilemma whenever you see a patient with this kind of presentation, what are you going to do next? Okay, so intuition is more like pattern recognition. Analytical is more on the rationalization. How do you manage the patient? All right, I'm going to leave it there for Prof. Ashari to take over later on. So as an emergency physician, we always have a good connection in between all the sides, from superior administrators, from our colleague and staff, patient's family. You cannot deny that because you not only manage the department, you manage the whole thing. You manage the whole thing. You are the commander of the ship, managing everything. So of course, it's everything also interrelated. Okay, everything is interrelated. So there is nothing you are alone. You are with the team, which looking into the whole perspective of how emergency department is being run and how the patient is being treated. And we are responsible to everything. The colleague are responsible to the staff responsible to us, the staff responsible for patient, for the administrator, the patient are also responsible of the our staff and everything. It's all interrelated. Okay. Well, let's look at another case scenario. Okay. An 89-year-old Malay lady brought in by clinic kesihatan with complaint of epigastric pain for 2 days. On arrival to your ED, patient is ongoing CPR and begging for the past 20 minutes from the KK. IV already dislodged while traveling. KK staff informed that patient collapsed while being assessed in their clinic. Had history of hypertension and diabetes. What is your immediate action? So unfortunate because we are doing the online lecture. If it's a face-to-face, then we can ask a few of you guys to answer. So I'm pretty sure the answer going to be set the team, prepare drugs, prepare for defibrillation, set IV line, intubate, continue CPR, adrenaline, everything that you can do. How do you going to resuscitate this patient? Fast and save life. That's how we've been trained to become a good emergency physician. I agree with that, totally. Who are we satisfying? Are we satisfying our needs as an emergency physician to save life? Are we satisfying what patients need? Are we satisfying what families' requirement? What we did is correct, accurate? Is it adequate? Is it humane? It's always a question mark because patient is 89 years old. CPR for the past 20 minutes. Are you going to proceed doing all the things that you know and you have learned as an emergency physician to keep the patient alive? We always having this dilemma, to do or not to do. Does doing something is good or is doing nothing is as good as doing something? So it's always as a dilemma whenever we manage the patient. So to come to this sense of when to start CPR and when not to start CPR, you need some experience. You need some life event that can say that please do not start CPR on this patient. Why you are putting danger to the other people when you do CPR. Example, now this in pandemic, some COVID patient, Cat 5, old, with multiple comorbidities, why are you going to intubate and CPR this patient while putting others in danger? We have to think. But it's a dilemma. It's not easy to say not to start CPR. It's not easy. To start CPR is very easy. You know, everybody came in asystole, you jump in, you CPR, fine. But when not to start CPR, it's difficult. When to stop CPR early is difficult. Once you CPR half an hour, 45 minutes, you're happy, you're going to stop, okay. If you're going to start or stop CPR in 10 minutes time, will you do that? It takes some guts to say, okay, enough, 10 minutes is enough, we stop. So it's not as easy as we think as to become an EP whenever you have more cases in hand, more things to be done, and more things to be considered in. So thinking like an EP, you need precision, you have to be timely, you have to prepare, you have to flexible. So what do you mean by precision? You high acuity, accurate, and dynamic. That cannot run away from any emergency physician. I think we are very clear on that from the first day you are in the master's program or you're an emergency department medical officer. You know we have to be high acuity. We try to be as accurate as possible, and we are very dynamic. Okay, the moment patient can be in green zone, the later patient can be in the red zone. Then we change according to it. And we are dynamic in emergency department. I think you all have gone through that training before. Timely, appropriate time. Is fast is only time that you will usually use, because we say always have to be fast, have to be fast. Is that true? Have to be fast? Or it's adequate is more appropriate words to be used? We usually see patient, the doctors are running when patient having fitting. Okay, we have a fitting case come in. Everybody was running to get things, to set lines. So I always say, guys, slow down. Patient is fitting. Why are we fitting together with the patient? Let the patient fit. We compose ourselves. Do what is necessary first. Head down, left lateral, get the lines, put in the lines. So no need to rush. So sometimes the fast is not supposed to be as fast as supposed to be, because we are used to be so fast. We are running for everything. So it's supposed to be adequate. Not everything is to be fast. Okay? Prepare best scenario versus worst case scenario. We hope for the best scenario, but we always prepare for the worst scenario. Please do not assume everything will go as we plan every day. Sometimes things goes beyond your capability, beyond your jurisdiction, and beyond your judgment. So always prepare. I think that is why emergency has become one of the department which is always very much prepared compared to other departments. So in this pandemic, you see some of our emergency department in Klang Valley, they are prepared for the worst case scenario, even though the case is much, much worse, but we already prepared for the worst case scenario. Just imagine if you haven't prepared for that. If you haven't prepared for that, so we are toast. But fortunately, we already prepared for the worst case scenario. Even the cases are very bad, but we're still standing. We're still standing. Okay? And flexibility, I think I don't have to mention this. As an emergency physician, you have to bend. You cannot break. You have to bend. You shouldn't be breaking. You should be bending for any issues which need you to bend. And you have to flex, because we are not the one who is brittle to break when any issues. We are the kind of which bend and flex for any issues. So the flexibility has to be there, because in 4 years of training of MED, and even before that, we were being trained how to be flexible. And I think most of you have already gone through that training to be flexible. So because you know, you plan for A, but the path going towards B or C, you are flexible. You can do that. And we have no issues in doing that, because most of our patients cause us to go flex. So we're able to do flexibility because of our patients. And how do we get this? One of the greatest things about being an EP is the opportunity to learn. Every day you learn something, every day. So you can learn from your colleagues, you can learn from your nurses, your staff, your residents, your students, and most probably the important part is your patients. Every day you learn something. Every day you add in something in your book. Every day you do something that you think this is a good life lesson that you learned today. So this is thinking like an EP. I also like to go into my second objective to say what are things needed to be a good EP. So I don't know. Just to declare, this lecture is more on my experience and my thoughts. So it may also not be agreed by some other EPs. So they may not agree with me on these topics or these comments, but this is purely my intention of sending this message to all of you. Okay, what are the things needed to be a good EP? Leadership. I think the video just summarized everything that the video that put on by the host earlier on summarized everything about leadership. So you need to rise above others. You need to rise above others. You have to be seen. You have to be there to lead these people. Okay, you cannot be the boss. You cannot just show people how to or order people how to do. You have to be with them doing things. Then only they have their respect. So the respect as a leader is much, much, much huge than the respect as a boss. The boss respect is more on fear. Okay, so the leadership qualities always differ. So as the video said earlier on, a boss create fear, a leader create confidence. A boss fixes blame, but a leader correct mistakes. A boss knows all, a leader asks questions. So to be a good leader, you have to be on the floor, working with them, seeing what's their problem, be with them during their ups and downs, then you understand better how to become a good leader. You cannot become a good leader while sitting in the office in a try to run away from all these issues, but just giving orders from there. It doesn't work that way. You have to be on the floor, be with them, together go through the problems. Then you can become a good leader. Of course, there are many, many other skills to become a good leadership. I'm not going to go through this whole topic on leadership thing. If you go through there are many, many books talking about leadership, how to become a good leader and so forth. Decision making. So once you want to become a good EP, you have to make decision. You cannot rely on other people's decision. You have to make your decision. But sometimes you see, to become a very good EP, you cannot just rely on your own decision. You also have to have some input from your colleagues, from your residents. So even though you already have your decision, what to do next with this patient or with this situation or with this condition, hide your intention, open for discussion. Let, let the people give you some ideas. What can be done next? What can we do next? What is the best management for this patient? Even though you already have some kind of decision making, you can keep the conversation power within you. You know what is going to be the next decision. If the discussion was given by other people, which is more logical than what your decision is, you can always change. Remember, taking other people's suggestion or asking other people's help is never been a sign of weakness for any EPs. Okay, asking for help is never been seen as a weakness. So only we think, oh, if I ask for help, it shows my weakness. Never, it never been like that. So asking for help, asking for discussion, asking for suggestion is never been a sign of weakness. So please do not have that thoughts. If you need or some other opinions, please go ahead and ask people before you make a final decision. Because at the end, the decision making is not benefit to you, it's benefit to the patient or to the department or to the environment. So do not think by having the decision by yourself, it's good for everyone. This is always happening in our organization. Some of the bosses will always make the decision, thinking that that decision is good for everyone, without even asking or without even get suggestion from other people. Is my decision is doing good for you guys or not? No. What their thought is, whatever I'm doing now is good for them. Full stop. Feedback, no need. I'm doing good for these people. So this is what's happening nowadays. So I think to be a good leader, you have to have this decision-making power with the input from all these people. Guys, am I going too fast, or can I get some feedbacks?
Okay, Prof.
Is it clear?
It's clear.
Is any issues? So can I proceed?
Yes, yes, Prof.
Okay. So the next will be on communication. I think I have to be a bit more detailed or dwell a bit more in this topic. Lack of words, when you don't talk to each other, when you don't communicate, it causes friction, it causes frustration, it causes confusion. And most of the time, it does happen in every department, and worse still in the emergency department, because we are dealing with many, many people. We are dealing with family, we are dealing with patient, we are dealing with our colleagues from different departments, we are dealing with colleagues in our own department. A good example, go to your observation ward, get one of the patients who's already staying there or already stranded there for a few hours or one day. Ask the patient, do she or he knows what her diagnosis is? Some patient will tell you, I don't know. Nobody tells me my diagnosis. Nobody tells me why I'm here. Why this thing happening? Because nobody speaks to the patient or speaks to the family. Just imagine you have a 20 patient in your observation ward. You are the only registrar or the only EP who going to do round in this ward with 20 patients. So from your perspective, you have 20 patients to be seen in that morning. So 20 patients for an EP to do round in the morning, it's not easy task. 20 patients is a lot. I agree. I totally agree with that. Just imagine for the patient. For that patient or the family beside the patient, you are the only one they are waiting for to get their progress and updates. From our perspective, we have 20 patients to be seen. From their perspective, you are the only one that's going to see them. So for this purpose, you have to put yourself into the patient's shoes. Think like what they think. So the perspective change. For you, they are just a patient. For them, we are the only one who treating them. That's why most of the time we do not remember our patients whenever we see them outside, but they remember us forever. So in that circumstances, why most of the time patient doesn't know their diagnosis, doesn't know what drugs being given, doesn't know why they were there waiting for a permanent place to be put into the ward, because we haven't have time to talk to them. So most of the time, I think the mother of all complaints and problems in the emergency department is poor or bad communication, because we have no time to talk to them, which is, I think, is absolutely not correct, because we have the time, but we choose not to talk to them because we think we are busy. How long will it take to explain to a patient regarding her or his condition and what is the progress of the next appointment or next visit? But we choose not to tell them, we choose not to speak to them because it's not our job, it's somebody else's job. So that's what happened when we have lack of words. We don't speak to people. The power of words, when you give information, when you share the knowledge with the patient, the good words and the good tone, it's 90% heal the patient. 90% heal the patient. And patient will feel so comfortable when you have the kind of doctors who talk to them, explain to them, tell them what's going on and everything, and update the families. Yesterday, I received a call from a friend from Penang asking regarding their son who's admitted to one of the hospital because of COVID. 7 days in the ward and then 4 days in the ICU. but they do not have any message from the hospital regarding the son's progress. 4 days in ICU, no information regarding the progress. I know everyone is busy, but still, giving the information to the respective people is very important to give them updates. So that is during pandemic, during COVID, but we are not giving information, not now, even before pandemic, we're not giving information. So is that correct? I think everybody has to ask to become a good EP, because become a good EP not only talk to patient, you also have to talk to your houseman. Talk to your houseman, to request your houseman to talk to patient. You have to teach them to do that now, not when we become an EP or become an administrator. When you have complaints, then you say, why you don't talk to patient? You have to tell them now, talk to the patient, communicate with them, share the knowledge. To some extent, you have to tell the patient, I'm giving you Lasix because of this and this and this. You should telling them. That is how we practice medicine in the world, but we are not doing this. So we give you medication, you'll be okay after this. What medication? We didn't tell them. They do not know. So sometimes the power of words have to be see when you want to make a good, when you have a very good communication with the patient, even though you have any other blunders happens after that. Most of the time, patient will not want to sue you or they not want to do a complaints because the communication from the beginning was very good. But you have a communication breakdown from the very beginning. Even how good you do, patient get admitted to the ward. After 1 week, patient passed away. They still going to sue emergency department because their experience from the emergency department is not good. Why? Most of the time, it's communication. Okay, it's nothing much about your skill, about you do some blunders. Not because of that. It's because of the communication. Okay. Sometimes mind your words. Okay. The more you speak, the more wrong purpose is happen. Every word must be very intentional and purposeful. Don't just speak without any good intention. Okay. Sometimes silence is best wisdom. So this is also apply when you're speaking with your colleagues, with your superiors. Sometimes it's better to keep quiet rather than to answer them back. Okay. And especially this happened during our communication with our superiors. Whenever we think something was not right, so we keep quiet. But there are things that you need to stand up and say. There are things that you need to keep quiet. And the worst thing, when you reply back immediately after any information being when you listen something and then you reply back without digesting it. That's the worst thing to happen. So as this quote says, the biggest communication problem is we do not listen to understand. We listen to reply. I think this is very true because we always reply. We always reply without even digesting what is being informed to us. We don't understand. We just reply first. Okay. All right. So still in communication, you know, argument is common in between colleagues of our side and from the other department. I think most of you have gone through this kind of experience in your life when you have a problem and discussing the case with your medical colleagues or radiology colleagues. No? So argument, okay. I'm not the one who's against argument. You can argue for the sake of the patient. Yes, go ahead. If that argument can cause benefit, can save the patient's life, go ahead. But if the argument is just to see your ego winning, then of course you will be winning the argument, but it's never a true win. It's just a moral victory for you, but it's never a true win. Okay, so so that that is the reason I said communication is very important in our fraternity, because we're dealing with a lot of people. We're dealing with a lot of people, a lot of other departments that we're dealing with. So whenever you raise your voice to justify your action, whenever you raise your voice to justify your action, you already lose the battle. because the voice raised is already a sign of the battle is gone. So whenever you speak to any department, keep calm, talk to them, justify to them. And most of the time, action speaks louder. You don't need to tell them you're not happy, right? They know that you're not happy. So how to win the argument? You do not need to win the argument. You just need to win the the, the just for that argument. Okay. Then how you need to also cultivate the confidence. How do you cultivate the confidence in the emergency department? You know, small success. Motivate your own victory. Okay. Set lines. You set the arterial line. It's a success. Motivate yourself. Okay. Your staff did a good dressing. Praise them. Okay. Your patient able to sit down from a difficult position. Praise them. Okay. You tell the family you take care of the patient very well. It's good. He looks very nice because your family support. Praise them. Okay. Because that's how you cultivate confidence. Small things. Small things. You cannot bring up the confidence of your team by looking at the bigger picture. It's very difficult to have okay, our department is the best department in the hospital, then only you're going to develop your confidence. No, it doesn't work that way. you know Everything have to start small. So you start small in your department basis. Small things build up the confidence. Small things, praise them. Okay. As soon as some of your staff pick up a rubbish from down and put it into the dustbin bin, praise them. That's cultivate confidence even from the smallest thing to become a bigger thing. So, all right. And confidence is good, but overconfidence is dangerous. So most of the time, this is what we see in my past 13, 14 years of becoming a specialist when we see new Emts coming in. So I always put this graph to them. It's a Dunning-Kruger effect. So when they come in, it become very high. So you already from know nothing of confidence. So you goes to the amount of peak of stupid. Then example, uh, intubation. You think are very good intubating. So suddenly you have one difficult intubation. You cannot intubate. Then you fall into the valley of despair. And then you start to have your slope enlightenment and become plateau of sustainability. So basically, I can put it in this way. So this goes to all skill or all knowledge. When you come to the Medic Masters program, you think you are in a very high institution after the first year exam. Then you know that a lot of things that you do not know. So you go into the valley of despair, and then you start to pick up all the knowledge again. And when you go to final year, you know that you are at that point of time, you are in the brink of becoming an EP. You know that, okay, I have a certain kind of knowledge. But of course, in the emergency department, the knowledge doesn't stop there. It always continue. The skills are always improving. Okay, stay committed. One direction, one project, one purpose. Make sure you do it one at a time. Okay. Multitasking, the ability to screw up multiple things at once. I don't believe in multitasking. You can be multitasker if you have a different job at a different time. It's okay. But one job, or different job in one time, I don't think so. Okay. I always hear people, or usually superior people, talking to us that, oh, I'm having 3 meetings, one through my handphone, one through my laptop, and one through my desktop. So I'm handling 3 meetings at one go. So I'm multitasking. When you are listening from the other side, it's not multitasking. That just shows that you're not interested in all 3 meetings. You just to be there because you need to be there. So you're not giving your all to any meetings. So that's not multitasking. Okay, that's not multitasking. That is just to show that you're not interested in all 3 meetings. when you're handling 3 meetings at one go. As simple as that. Okay, so because you're not focused, you're not directed, so you don't have any purpose for the meeting. But you still claim that, oh, I've gone 3 meetings at the one shot. It sounds good for you to say that, but for the one who's listening, it's not good. Okay. So most of the work of multitasking suggests that it generally makes you less efficient, not more. So be focused. Whatever you want to do, stay committed, be focused. One project, one time. You want to have multiple projects, fine, go ahead. But one project at one time, or one project at that time, not multiple projects at the same time. Nobody is able to do that. Okay, professionalism, gentle agreement, good support, caring. So you need to support your leadership. You need to support your colleague, staff, students. Okay, always strengthen the bond. All right, right is always right and wrong is always wrong. That is stands. Whatever it is, that stands. Okay, if the fellow that agrees with everything you say is either a fool or he's getting ready to skin you. So be careful on that, because you always need to support your colleagues. You know, during this pandemic, we have seen a lot of things come up. How the support, how helps from other friends to other friends. You know, I see a lot. I see a lot. So from my experience, I know how people in Klang Valley is in a dire straits of cases, and how much people from outside helping them, how much of people outside not helping them. So we are seeing many groups of people. Okay, so please help support. Okay, open disclosure. I think this is more on your topics. Try to avoid any promises. Stay open. Don't choose side. Wide angle discussion. Everything is about perspective. So I think this is more on professionalism. Try to be as professional as possible. Set negative emotion aside. Do not talk. Do not take any action when you are emotionally not stable. Okay, it can be destructive because it's impulsive, it becomes narrow-minded, it's always selfish. Because whenever you are taking any decision during you are emotionally unstable, it's first going to be because of selfish, because it's going to cause a lot of destruction. So do not take any decision when you are emotionally not stable. Regarding selfish, selfish, no kindness, no gratitude. Okay, what benefit give? So remember, selfish people don't care about you unless you are doing something for them. So that's about selfish. So I think everyone knows that. So let's go to other tips. Don't try to fill up other shoes. You can be a good EP on your own style. Okay, you do not need to be like Datuk Mahata. You don't need to be like Dr. Sarah. You don't need to be like Prof. Shari. You don't need to be like Prof. Sheikh Shari. You don't need to be like Dr. Ida, Dr. Surya, Dr. Khaldun. Do not need to be like that. You are good on your own thing. So go ahead. Go ahead. You will have your own shoes to fit. You do not need to fill other people's shoes. You will become your own legend by time. Okay. The calm rush, time management, I think you know this very much. Rushing is a recipe for disaster. Don't rush anything. Take your time. Okay. Time shouldn't control you. Stay in control of your time. So this is very applicable for your exam. Okay. You should be in control of time for your exam. Calculated risk, worth challenging with good knowledge, understanding. So I supposed to go in detail on this part, but I think I only have 5 more minutes, so I have to be rush. I have to rush on this thing. So always try to find new things, new ideas, and always open the room for thinking process and discussion. So like a guideline. Guideline is given for those who do not know what to do. So basically guidelines for stupids. So if you do not know anything, follow the guidelines. If you know everything, you can use the guideline with some new idea. So basically, if I put the question, if everybody in the world follow the guideline, how do they come up with a new guideline? That is the question. If everybody in the world of medicine following the guideline, then how people come up with new guideline? So if they're doing some research, yes, true, but the research is of course against the guideline. That's why they can come up with a new guideline, right? So that means people out there are always have nurtured new ideas, always open room for thinking process. So in Malaysia, we always follow the guideline created by other people. We never come up with our own guideline. That is our problem. Okay. So as an going to become an EP and thinking EP, I think you should nurture the ideas to think more. So lastly, knowledge and skill. You have to seek knowledge. You have to explore knowledge. You have to expand the knowledge. Throughout few years of being a leader in some of the societies, I've seen how people come up with try to explore new knowledge. I have people call me, I said, Dr. Farid, can we open up a section for underwater medicine discussion? I say, good, go ahead. So how Prof. Khaldun came up with venomation, snakes and everything. So he seek the knowledge, he explored the knowledge, and now he's expanding the knowledge. So despite what people are going to say, it doesn't matter, because at the end, he seek the knowledge, he explore the knowledge, he expand the knowledge. So what's wrong with that? So why are we going to be jealous with Prof. Khaldun? He's doing his part of expanding the knowledge for the entire world. So please do not be in the comfort zone whenever you become an EP. Always try to seek new knowledge, hunt for the knowledge, explore the knowledge. To get the knowledge, you can go to anywhere. To get the knowledge, you can seek anybody. You know, multiple gurus is better than one guru. Yeah? Multiple teachers is always better than one teacher. Get knowledge from different people. You'll get better. Managing administrators and boss. Okay. So for this topic, I think people always become speechless when it comes to how do you manage your boss. So you see, if you go Google up, there's many books, many topics on how to manage the boss and administrators, because everybody in the world knows it's difficult. It's not easy. Okay, my take on this is go with the flow. Just remember, you decide your destiny. The right always right, the wrong always wrong. You know better. Stand on your principles. Stand on your principles. Two things on that. You have your principles. Whenever something is going wrong against the principles, you say it out. Good thing. But nowadays, there are people who have their principles, but something going wrong on the other side, but they just keep quiet because secondary gain, tertiary gain, I don't know, but they try to keep quiet, not to mention their principle or stand on the principle. I don't know whether it's right or wrong, but I'm seeing that more and more this time. People when going up the hierarchy, being patient, having more stabilized career, all these kind of things, people are keeping the principles to them and try to be quiet, not to emphasize on their principle. I don't know, but personally, I think it's wrong. Your principle is a principle. If it's wrong, it's wrong. Okay, so I think you know better. So what required to be a great EP? Values, self-reflection. What is my purpose to become a ministry physician? You ask yourself. Balance. Always walk in other shoes. Your staff shoes, your patient's shoes, your patient's family shoes, your administrator's shoes. So balance yourself on that part. So get your true self-confidence. Accept yourself as you are. Okay. Show compassion. Show compassion. Demonstrate understanding. So when you have this, you have a genuine humility and you actually become a great EP. Okay? This is for your exam. I know you are stressed now. Good. Be stressed for your exam. When you come to the highest or maximum stress, you become a peak in your performance, you get better. All right. Ego is one over knowledge. The more the knowledge, the lesser the ego. The lesser the knowledge, the more the ego. This is said by Albert Einstein. I think everybody knows this. So usually whenever things happen, pause, think, reflect, and act. I like to use these quotes. Do not underestimate people's stupidity nowadays. and don't underestimate people's greediness nowadays. And this is for your exam. Do not strive for the purpose of passing the exam. But if you strive to become a good EP, you will definitely pass the exam. This is what I always tell my master students. So thank you, guys. I think I'm overshoot my time. Thank you very much. Whatever been said is all from my own thoughts, my own feelings to share with all you guys. Nothing. It may not be seen to others. Maybe my colleagues from even UKM doesn't agree with me, but this is all what mine. Thank you very much.
Thank you so much, Prof. We have about 2 minutes. Anyone has any questions to be asked? Okay, Prof, I have a question. What changes you see in yourself when you first started off as an emergency physician compared to now as a senior lecturer and consultant emergency physician? What changes you see in yourself?
That's very easy. Last time when I was a registrar. So I know all my staff are really worried when I was working on the floor. Because when they said Dr. Farid coming, they know, oh, things going to fly here and there, and all the patients must move out as soon as possible, cannot be in the department because stranded too long, because Dr. Farid will be shouting, my patient is stranded. So I think by time goes, we learn to understand that the problem is not only from our side, it's only from other side. So sometimes when you know that we are full, we want to push the patient up, but we never realize that medical ward is also full. They cannot push the patient anywhere else. So when you realize, when you go to their ward and see how the patient in their ward being put into the canvas in front of the toilet, so you know that, okay, it's good for the patient to be in my department rather than in medical department. So when you slowly realize, sometimes it's not only about us, it's about everybody in the fraternity. It's also about the medical people, it's about surgical people, it's about our colleagues, about our staff. So I learned from a difficult perspective on that part. So now I know that I tell them, okay, do not need to make people scared of you. Just let people love you so that they will work better. So now I hope my department people loves me, so they work better. They don't scare to approach me anymore, like what happened before. So I think in that perspective, I changed a lot. And of course, I think while time goes, the more experience you have, the wiseness and the maturities become more prominent, then you know that sometimes the decision being taken is a different perspective altogether. So actually you change your perspective.
Thank you, Prof. There's one question from the floor. What is the greatest challenge when you become an EP in a new place?
There's always going to be a challenge whenever you go to a new place. It doesn't matter as an EP or as an MO, as a staff, it doesn't matter. Whenever you go to a new place, you're going to change the whole adaptation of your life there. So you cannot ask them to change as you wish. You have to change as they wish. So that's why an EP is with a high flexibility and you can bend over to anything. You can cope very well in any other circumstances or environment. So first, if you go through all the steps of bereavement, anger, denial, acceptance, at the end you go through. So it's going to be the same thing. You go to a new place, you're going to see why things happening this way, why happening this way. You have to adapt first, and you have to accept, then you have to move. For me, I think wherever you go, they're going to be challenged. Then the best present for your life is to take the challenge and improve yourself in that side. And I also believe wherever you go, there will be something that you can change to be better. So change for betterment. So always people say, example, one hospital, they have a very good system. The system is perfect. If you go there, the system is already perfect. There's nothing is perfect in this world. You go there, of course, you can change something to become much better. So change it. So when you be in the system and change the system, that become a challenge. And that challenge will get you names, will get you fame, and people will be looking you high in that side. You know, the greatest challenge for any EP, any site is to establish yourself. How to establish yourself? You have to give. You have to give your knowledge, you have to give your energy, you have to give your time for the betterment of that site. So whenever you give, you will get back. So the key point is to answer your question is, are you ready to give? So if you're ready to give, you will get. So I would suggest for any EPs to go anywhere, prepare to give. Give your knowledge, give your time, give your energy. When you give everything, you see what you get back. Actually, it's more than what you expect.
Okay. Thank you so much, Prof, for sharing with us all your experiences and also knowledge. We would all have got more information on it and try to be a better emergency physicians soon. Okay, with this, thank you, Prof, again. Our
Thank
next
you.
topic, thank you, Prof. Our next topic would be on clinical reasoning. Is emergency medicine different from any other specialty? Okay, we invite another speaker from HUSM, Associate Professor Dr. Muhammad Hashairi Fauzi, to share his perception on this. He's a senior lecturer and consultant of emergency medicine in University Science Malaysia. His special interest is in emergency ultrasound and critical care. So without much ado, let's welcome Prof. Hashairi. Prof,
Okay,
platform yours.
okay, Assalamualaikum. Can you see my slide?
Yes, Prof, can.
Okay, sorry. Why it looks colorful, my face, eh? Let me check first. Maybe the background, is it? The virtual background.
Ye off background je.
Yeah. Oh, okay. Nampak colorful lah di pagi ni. Okay, thank you, Dr. Kangita and team. Okay, my fellow speakers, Prof. Sheikh Farid, Dr. Sarah and Datuk Sri Abu, and the fellow lecturers from UKM, and of course, ladies and gentlemen. So I'm, honored to be in this CME this morning. So when Dr. Ida asked me to talk about this topic, clinical reasoning in emergency medicine, how different with others. So it's quite challenging topic for me, but I'm trying my best to explain what actually we have been done in emergency department. And of course, like Dr. Prof. Farid mentioned, in emergency medicine, our approach a little bit different with others discipline. However, everybody have their own opinion, their perspective when managing patient. So I just mention here every one of us had the different background, different experience in academic work journey. This session purely my sharing session through personal experience and some readings. So maybe my approach is a bit different with others, but the possible we share something in common when we managing patient in ED. And I would like to acknowledge also Prof. Chu and also Prof. Saiful Bahari from USM, Prof. Chu from UNIMAS, because when I received this topic, I also discussed with them. As we know, Prof. Chu, one of the champion in the clinical reasoning in ED. So we share some thought about this, how we should, as emergency medicine, how we approach patient in our ED. It's nothing heavy here, just sit back and relax. And I know this is the very beautiful morning and, sunset. And we love to see this photo again and again, during a pandemic. So we cannot travel, But this is Hulu Malay, because I know some of you from Maldives. So when we back in 2019, when we our group invited us to went to the hospital in Maldives, sharing about the ultrasound that time. So we love to go to the Maldives again and again. And as Dr. Kangita mentioned, you have the two candidates from Maldives. So Maldives is a very beautiful, it's amazing place to go. They have almost 2,000 island, if I'm not mistaken. So maybe after COVID pandemic, we might go there again. So very interesting place to go. And for those who never come to Newcastle, Kota Baru, so this is our emergency department here. So we are welcome anyone to come over here and share with us. Okay, so when we talk about the critical reasoning, we have a lot of many questions, too many questions to look for what actually clinical reasoning. And when people ask us, are we truly different with other discipline? And if we are truly different, what makes us different with other discipline? And how about the decision making? How about the diagnostic error? And of course, people talk about, like Prof. Talked earlier, talking about the the DPT, the dual process theory, in terms of a cognitive bias. So I hope when we go through this session, it might answer a few of these questions that come across in our mind. Yes, not only, as when we work in ED, we make a decision, but in our life, we make a decision every day, hours, minutes, and seconds. What we are or how we live our life are largely determined by decision we make. We first make our choices, then our choices make us. So this is very important. So how we think is very important, because it's determined how we make decision. And later it will determine the two major aspects of patient care, which is the establishing the diagnosis, as well as we develop treatment plan for our patient. So the thought process when we encounter patient, how we deal with the patient and came up with the diagnosis, it's very important step. And later when we had the few diagnoses, and we continue with our treatment plan. But like Prof. Farid mentioned, in ED, we're dealing with the uncertainties, from wide range of patient, from neonate patient up to the elderly patient, and from green cases up to the resus cases, so we dealing with a lot of uncertainties. So I think Prof. Farid already highlight, but I just want to highlight the why I always told my colleague or my student that our thought, or basically the approach, is a little bit different with other discipline. Why? Because of few factors. For example, here you can see in the middle, we need to consider a few things in terms of, for example, time, okay, and stress. Of course, in ED, we have limited time compared to other general medicine. And stress, of course, in ED, we have higher level of stress, and the flow of process, most of the time we have a spiral, multi-direction process. And of course we have the short-term target, workable option, higher stake, and we have the multiple players. And of course the goal and task sometimes not commonly, which is ill-defined, the goal and task. And the gap, we had a lot of information sometimes. Why the gap? Because we think a lot when patient come to us. And of course in ED is dynamic, and the other factor like action, the sometimes we just jump on patient when of course we need to jump on patient when patient come, collect patient for example, and we don't have time to think. I mean, not have time to think. I mean, in short period of time, we have to analyze patient as soon as possible, and of course, differential and management little bit the different. Okay, and of course, with the at the same time, we need to make sure the margin of error is little bit narrow. So this factor actually uh, contribute to the differences between our specialty compared to other discipline. And one of the important difference is how we approach patient. Uh, basically the thought process. Okay, of course, when we see patient coming up with for example, when in early shift we pass over patient and we looking in one patient, looking for diagnosis, for example, as a registrar or senior MO. So of course, at the same time, we switching the task, and because we need to see a lot of patient, but at the same time, a lot of interruption. Sometimes our MO come to consult us, show the ABG, for example, show the ECG, and then we have a lot of task switching. We have a lot of interruption. A lot of people come and discuss not only MO but sometimes our staff, supporting staff also come to tell us about for example the admin issue. So of course, when we come back to the to patient A, uh, we have to do some debiasing potential cognitive bias, which I will talk a little bit later on cognitive biases. Okay, so we need to train ourselves how to approach patient with this during this kind of condition. Why this is very important? Because it's well known that the emergency department is one of the department that have a little bit higher diagnostic failure rate um, because of the complexity uh, in making a decision. For example, in emergency department, because at that point we are a lot of uncertainties, and with the high stress level. So some study mentioned the diagnostic error in this area range from up to 12%. I think quite you know um, higher compared to other discipline. So when we people do further study on this, looking into why actually in ED have the high diagnostic error rate, and they found that usually it's not because of lack of knowledge. We know that our from registrar, Emts, they have knowledge. The diagnostic error is not happen only in in Emts or registrar level, but sometimes the specialist, the consultant, in fact, doing also some this problem, and this problem actually is not because of a lacking of knowledge, but of the cognitive error, how the clinician think at that time, because a lot of factor involved. So from this study, it's mentioned up to 75% is because of cognitive error. It's not because of the lacking of the knowledge. And why this important? Because the ultimate goal basically patient safety. If you have the diagnostic error later, it can affect patient safety. So that's why we need to understand a little bit when people talk about the cognitive thinking later. So now clinical reasoning. So in by definition, the clinical reasoning is just process of gathering and understanding information. It's just a thought process that guide our practice. We gather the info, and understanding the info is it's thought process. So So when people discuss about the clinical reasoning, they are outside there a lot of model, a lot of model. I think the Prof already discussed a little bit on DPT, the dual process theory, and apart from that, we have the hypothetical deduction model. This is classic model, the traditional approach, which is when patient came, they have the few differential diagnosis, and they do a lot of investigation to rule out one by one. So I guess this is a classic, teaching before for undergrad. So we take history, take the, the physical examination, and we came out with the differential diagnosis, and we rule out one by one. So that is hypothetical deduction model. And we do have the, what we call the pattern recognition, whereby I think now people moving a lot of to pattern recognition. In fact, they develop the AI nowadays also based on pattern recognition, gives some info to the machine, and then about the pattern recognition. So when give some info and they recognize this pattern, and they came out with a few differential diagnoses. But the most people talk about dual process theory because this is very close to us. So what is the? I know there's another model of thinking, but the for today we just discuss the dual process theory. Okay, for the dual process theory, as we know, this theory have been with us almost 35 years ago. One of the major development in cognitive psychology over the last 20 years, whereby they have two component, the system one, like I think Prof just give some idea to us just now. It's about the intuitive as system one, and analytical thinking for the system two. So what is a DPT actually? The dual process theory, by the name we know we have two process of thought. So the system one is more to intuitive, which is experiential, heuristic, pattern recognition. So basically the DPT combine the pattern recognition model and also the the hypothetical just now theory. So they combine into one thought or thinking cognitive process, which is dual process thinking, the system one and system two. So if you look at here, the it's almost for system one is fast, high capacity, high emotional attachment, more to pattern recognition, or what we call the heuristic, mainly, for example, people say it's like gut feeling. And system two is more detailed, more slow response, and have the low emotional, and they have the systematic approach. These two systems have pro and cons. For example, in system one, they have the error prone. So because lacking of information, for example, and high emotional attachment, and most of the time, sometimes we follow our gut feeling. Gut feeling ni kalau pagi-pagi tu kan tak breakfast lagi lah. So gut feeling macam hari ni tak breakfast lagi. So gut feeling tu mungkin lain sikit. Tapi kalau fulfill the gut feeling, sorry, I mean, it's just joking. So basically, the system two basically more detail, okay, with more information, and of course the system two, if we look at the more reliable in terms of the how we reach the our decision making. Okay, so how it's work actually. So sometimes what we do now actually we already have in our mind our cognitive. We have both actually, system one and system two. So for example, here when patient came with the to us at triage, and we do have chief complaint, everything. So we with us we already have the pattern of recognition process. If we recognize, we straight away go to system one, so and came out with a few, we do some calibration and proceed with the decision making. But if we don't recognize, for example, difficult complex cases, for example, so most of the time we need to, dig further, do some um, what we call the analyze the data, or review the investigation result before we come to the diagnosis of the patient. However, if by experience, from you can see here the novice, the beginner, advanced, expert, sometimes they can bypass this. So by years, I mean by experience, you can bypass from system to this to the system one, especially in common case. You have seen the cases every day, so, or you see cases that you do some diagnostic error, and do some audit, and you remember that, so it's consolidated in your mind, and that's give you some idea. So I mean, in terms of experience, you can train yourself from system 2 to system 1. This is an example how we differentiate between the system 1 and system 2. So 4 friends are going to buy a new smartphone. Who uses system 2? Who uses system 2 thinking to choose which phone to purchase? Okay, you can see here, for example, sorry, the name is not related to siapa-siapa, sama ada yang masih hidup atau yang telah mati. So A is Surya buys the iPhone because Apple is a cool cutting edge brand. Ida buys Samsung because he always bought Samsung in the past and they were always good phone. Ni Azlan buys the Nokia because it has high megapixel camera, a fast processor and lots of memory at a lower price than other phones with similar features. Hashim buys the Oppo phone because the screen resolution and design look great. So what do you think? Among 4 friends ni, which one uses system 2 thinking? Okay, so I know most of you will choose C, yeah, because we can see the C, Ni Azlan have the detail, they analyze the product. Okay, others basically looking into because they know because of the trend, and because the experience have using the, for example, Samsung, Dr. Ida, another Ida, bought Samsung in the past, and they were always good phones. So they just follow the previous experience. So, but the system 2 get more detail, do some research about this product. So that's the difference between system 1 and system 2. And again, like Prof. Farid mentioned about Dr. Pat Crossgrace, one of the famous EP in Dalhousie. They one of the figure actually talk about the clinical reasoning. So most people who work in ED have brain that are automatically in system 1. Your brain doesn't consult you, it sees a pattern and react. I think most of us in system 1, in initial stage when we managing patient. But the key is to know when to get out of system 1. So this is very important. Okay, most of us, okay, when we manage patient under system 1, very quick, we recognize, do some pattern recognition. Okay, some might say there is no shortcut to that kind of acumen. You have to get burned and get a lot of miles under your belt. Okay, but we have to train ourselves. We have to train ourselves to, in certain condition, we have to get out from system 1. Okay, because as we know, the system 1 have the error prone compared to system 2. There is certain condition where we need to get out from system 1. Okay, we go further and we discuss a little bit later. Okay, so as we know, the older system 1 is the fast reflexive thinking mode that we commonly use. Okay, and most of the time the system 1 require heuristics. Okay, heuristic. So what is heuristic? I think Prof. Farid already mentioned earlier. So heuristic are mental shortcut or rule of thumbs or gut feeling. Okay, ini kita selalu suka ni. rule of thumb, or gut feeling used to assist us to rapidly make decision without formal analysis. So far so good ke, Dr. Kanita?
Yes, yes, Prof. Good. So
Okay,
far, so
thank
good.
you. Dengar cakap seorang ni. Uh, okay, anyway, okay. So, apa maksud heuristic? Okay, heuristic, as we know, and of course, most of us practice this, but we actually not aware what the suitable term to use. But the heuristics is almost similar with our gut feeling. Okay, they have the two heuristic that are considered essential for clinician when faced with an emergency situation. So number one, rule out worst case scenario. Why we need this? Because as we know that diagnostic failure is quite high in ED. So we need to have the rule out worst case scenario. And we might ask ourselves, is this patient sick or not sick, ill or not ill? So this example, so we have another example, okay? And this pattern recognition or gestalt feeling in what is form of the heuristic actually, heuristic. And based on this study, not only in, in, like I mentioned earlier, not only in ED, we spend about 95% of our time making decision in the intuitive mode, type 1 thinking. If you realize, in our life, you may compare yourself and your wife lah. And I'm not sure, um, um, because my wife is the histopath, so they go in detail about something, but me as the emergency. So sometimes at home, we if we discuss something, we cepat, quick come to the decision, okay. But my wife sometimes takes time to analyze and give little bit time for her to think. Kan? I'm not sure if you married your husband and wife as emergency physician. Try to compare the thought process. I think emergency physician almost have the system one thinking. But if you have, it doesn't mean not good. You married with the same discipline, but this is just a thought process. So we need to have the another system too, which is slow down a little bit when we want to make a decision, especially the big decision in our life, for example. So try to simulate or try to think in different ways, especially when we come to a very big decision. Okay. And this is a very interesting study. They look into the functional MRI activation of the brain as a function of practice over 60 minutes. If we compare the novice, katakan, houseman ke MO kan, and intermediate, MET katakan, and skill specialist, over 60 minutes, you can see, look at the brain activation. Kan? Skill ni, specialist ni almost brainless ke? I'm not sure. No, I'm just kidding. So, I mean, the activation, the novice, they think a lot. When patient came to at our door, which you complain of chest pain, for example. So they might think activation of brain, a lot of differential diagnosis, a lot of information they want to gather. But intermediate, okay, you see the activation little bit lesser. But those skill, consultant ke specialist tak banyak sangat dia fikir. So dia maybe because of dia punya experience, so dia hanya pattern recognition they know can come to the diagnosis. This is what they have been studied. So very interesting, which is of course, like I mentioned earlier, because of the exposure, the experience, so we have a different thoughts. So I touched a bit on the cognitive biases because as we know, the cognitive biases contribute a lot in diagnostic error in ED. How many minutes I got, Dr. Kanita? 50 minutes, is it? Another 10 minutes?
Another 50 minutes.
Okay, thank you. So what is cognitive bias? I guess I need to dwell a little bit on this because, like I mentioned, the cognitive bias contribute a lot in our diagnostic era. So cognitive bias is the systemic error in thinking. Itu je sebenarnya. Systematic error in thinking when we, process and interpret the information. And in terms of thought process study, okay, and of course this will affect the decision and judgment that we take later. So when we talk about the cognitive bias, they have what are the common causes of cognitive bias? Few factors involved. For example, we sometimes we limit on our attention. So our focus, of course, in ED, we have the short attention span, and sometimes come to when we definite, we think that's the diagnosis of the patient, and sometimes we stick to that diagnosis even without thinking other differential diagnosis. Okay, and mental shortcut like heuristic, for example, sometimes our gut feeling not really not fully full of gut. So our mental shortcut sometimes make a wrong decision. And of course, when we do make it decision, the emotion also involved, and we are in high stress level, a lot of emotion involved. So it also might alter or affect our thought process. And of course, the social pressure, the peer pressure, for example, can sometimes, the environment, people around us, and of course the individual motivation itself. So a lot of factors involved. And of course, during pandemic, sorry, I'm not a stalker, but uh, sekolah ya, so I ambil gambar ni. So the one of the during pandemic, the what we encounter a factor that's affect our cognitive is the mental fatigue. And of course, we work long hours managing patient, and we have a lot of patient because all these factors will lead to the cognitive bias. And of course, cognitive load, because when there is a lot of patients stuck in our ED, critical ill patient, like your place, a lot of patient ventilated, you need to go one by one, a lot of information need together. So with the mental fatigue plus cognitive load, that's why come the risk of the cognitive bias. So when we talk about cognitive bias, there's a lot. I'm not going to discuss all, but from the study, they said almost 100 cognitive biases. So we only focus in few things that they I think are relevant to us. So one of the cognitive bias is the what they call the availability bias, which is, for example, the thought process said, I remember seeing a similar patient with diagnosis X, therefore this patient must be having diagnosis. This an example. So you have your experience, you have the available info before, so you might had the similar experience, and you might say this patient have the similar diagnosis. Anchoring bias. From the very onset, it seems that this patient is having diagnosis X, so he must be having diagnosis X. So anchoring bias mean from initial, for example, people, your friends say, oh, this is definitely ACS. So without thinking other differential diagnosis, so people continue with this. Okay, confirmation bias. Since the patient has diagnosis X, I must look for evidence to support this patient had diagnosis, which is you narrow your mind. It's quite happening lah masa kita pass over, for example, kita ambil daripada orang lain case, pass over case, so okay, everyone dah settle kan, semua dah settle, this diagnosis is for example ACS or apa ni, pulmonary embolism, for example. So everybody look at this as established a diagnosis without searching for next, they call it search satisficing. I have found it as this patient and I am happy with it. So everyone happy since the MO pun dah tengok, the registrar pun dah tengok, and medicals pun dah tengok dah. So we agree, so this is the diagnosis, and we take for granted that we just follow the flow. Okay. Another bias is trash queuing is almost overlap, almost similar. When the trash officer found that the patient has diagnostic X, let's treat the patient as having diagnostic X. This happen usually in junior medical officer or houseman. You just follow, oh tak apalah, trash officer ni senior dah. So maybe her or his diagnosis is correct. We just follow the diagnosis. And next is the diagnostic momentum. Like I mentioned earlier, the HO say the patient has diagnostic X. The MO also does say X. The specialist also will do round, okay, agree this. So, and nobody is challenging it. So this is an example of the ini. And of course, yani quite happening, I mean, in our ED sometime, but the other cognitive bias like cost fallacy, mainly because I think more to the inside the ward when they have invest so much money, time to having diagnosis of X, and so they already dwell on that diagnosis only, so doesn't think about the other diagnosis. And there is a lot of other cognitive bias. I guess you may read about this, but the other things that I think are important, for example, ego bias. Ego bias ni everyone have their own ego, but um, when we refer to someone, uh, uh, you know that's why I think Prof Farid already highlighted just now, don't raise your voice but raise your argument. Okay. Ego bias mean they have their own ego, which is they said, okay, I statistically speaking, my patient often do better than patient from the other team. Maksudnya dia rasa apa yang dia decision dia buat tu adalah betul, and they said because previous experience apa yang dia buat tu dia much better than other team when managing the patient. So it's very dangerous to this kind of I mean in terms of making diagnosis, and a lot for others cognitive bias. Busy slide, but I just want to highlight an example of few biases. In this case, the anchoring and search satisfaction bias. If you can see here, I just give a summary. 21-year-old trauma patient had the arm, chest, head injury, but basically because of this injury mainly obvious over the chest, so they focus over the chest only. And 5 days later, the patient present again, a different hospital because of vomiting, blurred vision, and a CT head revealed the basically patient got the head injury, a penetrating head injury. So because initial one, they do some investigation towards the chest, they forget about the head. So this is an example of the anchoring and search satisfying bias. The resident and attendant staff anchor onto the chest wound, which is focused to chest wound as most significant injury. So, and they really satisfied themselves on chest wound, was stable, and resident failed to conduct the significant injury. So this an example. I think, yeah, quite common happen also in our center. So this is another example. Sorry for the busy slide, but this scenario just to highlight patient on psychiatric patient. Okay, diagnosed in GP and the GP follow up, and referred to ED because of throughout pneumonia. So when our resident, ED resident, see the case, we do some routine blood work and chest film, and all normal, and we believe that this patient is not much into the respiratory problem, but mainly to the anxiety problem. So while she wait for transfer, she become very agitated, short of breath, and several nurses attempt to settle her, encouraging her to breathe into paper bag. Shortly afterward, loses consciousness, patient collapse, resuscitate, and patient succumb to her illness. And autopsy found there is a basically patient had this saddle embolus, which is quite basically the PE. So the of course we do have also some experience when patient psychiatry is one of the a challenging patient to manage because they have underlying disease, and we sometimes underestimate them. So this cognitive biases, for example, momentum, because momentum mean the bias mean from the GP already diagnosed that, and then come to ED, we have in our mind, because other doctor already diagnosed patient have the anxiety problem, so the diagnosis is very clear. So we might think a lesser, a worst case scenario, we might think, oh, maybe this anxiety. Okay. And framing mean because may also have been a problem since the secretary had specifically asked the ED to rule out an infective process. Okay, framing mean we have been, someone referred to us to rule out other disease. Okay, for example, here to rule out pneumonia because suspect pneumonia. So we framing mean our minds, oh, just pneumonia. We're working for pneumonia. If X-ray normal, we discharge patient. We don't look for other bias, which is search satisficing is again a problem where we satisfy just now with the other people's suggestion, and we follow their diagnosis as well as the decision decided by them. Okay, I just skip this one because we have the it's almost similar, but the apart from cognitive bias, another factor that contribute is affective bias. Affective bias, I think, as we know, a lot of things happen not only when we make it decision, not only thought process involved, but the environment, for example, the ambient condition, the environment, resource limitation, the clinical situation, the cognitive load, the passion factor, the fatigue, the distraction, and of course the another factor is the uh, endogenous ourselves, within ourselves. Sometimes we don't have the enough sleep, emotional, a lot of emotional involvement. We have the personality problem. All this can alter the our cognitive. Making a decision. And a few minutes discussed a bit on the debiasing strategy and how we improve, how to reduce this cognitive bias. There are a lot of, you might see and find in internet about the debiasing strategies. So they have the universal and generic thing here, but I just focus to the specific debiasing strategy that we actually normally do, but sometimes we not realize it. So we have few things specific, for example, bias inoculation strategies by training, okay, simulation. We have the rebiasing strategy, specific forcing function, and checklist. In myself, normally I mainly do the cognitive forcing function when we do round. In contrast to heuristic, the gut feeling just now, the cognitive forcing strategy are a specific debiasing technique that introduce self-monitoring of decision making. So when we make it the decision just now, and we ask ourselves, okay, we slow down a little bit, step back and look at, are we sure about that and why? This is a mnemonic slow, they said they use this mnemonic. Look at the data, which is lacking, does it all link together, or is opposite? What if the opposite true? And W is a worst case scenario. What else could this be? So ask ourselves when we are dealing with our patient. Okay, so this another example of a rule out worst case scenario. For example, those don't put the anxiety disorder, somatization disorder, the conversion reaction. Remember, all this psychiatric illness is, I guess, all of us already know about this. So just a recap. So it's diagnosis by exclusion. Okay, patient with back pain always force sometimes our thought to exclude other what you call the life-threatening condition. Okay, so this another method how we perform the cognitive forcing function. Okay, always ask these two questions before discharging any patient from the ED. Why did the patient come, and have I made the patient feel better? So this is another example of cognitive forcing function, because to reduce the error we normally use in system 1, so we have to have the strategy to reduce that kind of error. Okay, so ultimate cognitive deficit strategy. If you do remember, you might use this term. What else could it be? What else could it be? I think we have a same experience last week when patient came to us in ED with young patient, para one, 10 days post-vaccine, came with the chest discomfort and palpitation that time. So patient came with the sinus sticky. So everybody examined the patient, and they, when they examined, they found this some neck swelling and some tremors. So they think of the maybe patient had a thyroid problem. So because of the sinus sticky, tremor, neck swelling, they might think of thyroid problem at that time. And because of percentage taking 150, 140, so they try giving patient the IV beta blocker. So, but when they repeat twice, the heart rate is not coming down. And luckily, we have another person come and patient already from research that time. Sorry, from the yellow zone, and sent to the our ward sementara. And then when they give the monitor the patient, give the beta blocker, so the heart is not coming down. So that time another doctor come and revise, try to anything else it could be, because sometimes when in thyroid problem, thyroid toxicosis, you give the beta blocker, the IV propranolol, for example, the heart is coming down. But in this case, it's not coming down. In fact, maintain and sometimes a little bit higher. So they dig further. So because post-vaccine day 10, so is it possibility this patient having the, because echo is normal, the lung is clear, but because of the suspicious, and they had the history, patient had history of taking OCP also, young patient, para one. So so they might think of other causes. So they send a D-dimer come back is positive, prostate CTPA, actually patient having PE. So it's rarely happen, but because our thought, everybody talks about the thyroid because clinical appearance, but if there is no response to some medication, we might think ourselves reverse the diagnosis. Not reverse, I mean look another factor or another cause of the tachycardia. So I just showed this photo because I still remember when I was young. I'm still young, but when Prof I think that time I was second year met here. So I was asked to bring that time accompany lah, masa tu Prof Ismail. I think Prof Ismail is here, is it? Prof Ismail. So and then he asked me to, bawa lah ke mana pun. So that time before after, I think after exam finally at that time. So I brought him to the one of the cabin mall lah, salah satu tempat di Kota Baru ni tak banyak shopping center like KL lah. So I'm not sure some other pros might ingat ke tidak kisah ini, tetapi I will remember because pros might also our guru. So he taught me few things when we managing patient in ED. So one of the method he taught me is this. Okay, 5 things you need to ask. Okay, and I realized this is one of the forcing, what I call the just now the function, cognitive forcing function when we managing patient in ED. Ask first, patient come with the chief complaint, and the first thing in ED we look for the life-threatening cause. For example, chest pain. So what are the life-threatening chest pain first before we jump to the common cause of the chest pain? And if we satisfy everything, now if you want to discharge patient, you ask yourself, safe to be discharged or not? And if discharge, is he or she require follow-up? So I always use these 5 things when we managing patient ED. I think thanks a lot to Prof Ismail, our guru also talk about this method, one of the method. So other guru have their own methods when managing patient in ED, not only in red zone, but in green zone is also is very looks okay, but green zone is quite challenging zone, and also the yellow zone. Okay, because red zone sometimes is straightforward. Okay, this one of the cognitive forcing function. Okay, so in conclusion, I guess knowing and understanding the system 1 is into thinking and also their limitation we can avoid in our life, in our work, Every day we use the system 1 and system 2. And of course, we need to recognize the cognitive biases and irrelevant affecting our decision. And of course, able to apply appropriate debiasing strategy, which is I found that the cognitive forcing dysfunction is one of the methods we always use in our daily work. And of course, know your limitation. Ask your superior if you are not sure. Junior, ask the senior if you are not really sure what happening. Okay, so my last word, bekerja lah, walaupun malu. I think all of us know about this. Okay, and being an intensivist, I have to work many different specialty. I think not me. I think this is a quoted from other ICU friend. I respect all of them, but I have to utmost respect for emergency medicine. Why? Because for both of us, nobody is too unstable to be helped. We jump into the fire without second thought. So that's why ED 95% are using the system 1. Okay, and don't forget, maybe some of you tak ingat lagu ni kot. Masa saya muda-muda dulu, I still remember this song. Pandangan mata selalu menipu, pandangan akal sudah salah, penafsu selalu melulu, sepanjang hati itu yang hakiki. Saya nak nyanyi pun saya tak sempat dah masa. So kalau hati itu bersih. So I think the relation between the mind and the soul also is very, very important. So the soul is very important when you have the fill up the soul with the flourish, the positive thought, every positive think, and positive, a lot of positive energy. So they translate to your mind. Okay, so I hope, I'm sorry for taking extra time. So I hope you enjoy the session. Okay, I think that's all from me. Thank you.
Thank you so much, Prof. Shairi. Does anyone have any questions to ask him? Okay, we are at 10:25 now. Okay, thank you so much, Prof, for sharing with us your experiences and knowledges. I'm very sure, I think we have much more to think about and put it into action to become a better emergency physician in future.
Okay, thank you.
Okay, thank you so much, Prof. Okay, let's take 5 minutes break. Dr. Sarah is already with us. We'll join back at 10:30. 5 minutes breaks.
Doctor, I think I need to leave the meeting. Is it okay? Because yeah, I also involved with the fellowship Viva.
Thank you so much for spending your time.
Thank you. Yeah, thank you so much.
Okay,
Thank you everyone. Okay, bye-bye.
Okay, we'll be sharing the QR code for the CME point. Okay, welcome back all. Okay, it's already 10:30. Our next speaker is Dr. Sheikh Abdul Karim. Okay, she's actually a senior consultant emergency physician in Hospital Sungai Buloh, and she's been involved in the setting up and managing our PKRC centers, Emts, since the beginning of COVID pandemic. Okay, let's welcome Dr. Sarah for our next topic, which is pushing boundaries in emergency medicine in the time of pandemic. Where do we stop? Dr. Sarah, the platform is yours.
So, semua boleh nampak skrin saya ya?
And Dr. Sarah.
Alright, good. Sekarang I can stop showing my face. Thank you very much everyone. Esteemed chairperson, team UKM and also colleagues students semua. So topik ni tak ada banyak teori. It's just mainly kita akan share some experience and share through what are the things that we have done slowly to improve during the pandemic. Okay. So when we look at pushing the boundaries, then the first thing we must ask ourselves, is there a limit to boundaries of expansion? Well, there are two things yang kita always have to look at. That the sky is not the limit because we've sent people to the moon and we've sent rovers to the Mars. So therefore, sky is no our limit. But I guess what is important is that we do not make our mind and our perception as the limit to what we can do. Yeah. And what is more important is that we understand that throughout our whole career, there is this going to be a reflective learning and practice process that we must undergo. Now, pandemic. This one I like to quote when they initially start to declare the COVID-19 as pandemic. So WHO president made this remark that the pandemic is not a word that can be lightly used carelessly. If misused, it can cause unreasonable fear, unjustified acceptance that the fight is over, leading to unnecessary suffering and death. Yeah. So a pandemic is just a situation. How we handle the situation, how we suppress it, whether we do or break, and it's a matter of question whether we will. Yeah. So when the term pandemic is always used, then we must understand that it gives us a picture of a lack of capacity, lack of resources, but never lack of, actually bukan resources, but never lack of ideas or resilience. Yeah, I'm sorry ya, ini kesalahan letak. Now, a pandemic actually affects the whole healthcare system, and we are unique. In the EMTS, you are in the middle of the system. Okay, so what do we mean by you are in the middle of the system? The first one, you have to view from the patient cycle. A patient can come to department or hospital or even a screening center through two pathways. One is through the ambulance, another one using their own personal transport. At the end of the day, they come to something, a setting somewhat similar to an emergency department. An emergency service is there in all facilities. Even if you say kesihatan awam and klinik kesihatan, they also have their own small emergency unit. So emergency medicine is the doorway to all of the healthcare service. Yeah. Now, at the emergency department, if you look at the traditional hospital setup, you can either go to the ward or you can go to a critical care service. And the life cycle of the patient later on goes through rehab or step-down centers and get discharged home. Yeah. So dalam bab ni, if you look at the red highlighted areas, this is our core domain. This is where we start. Ambulance service, pre-hospital care to a patient that is able to be transferred safely to ward or critical care areas. In between, they stay with us. Yeah. But in the pandemic kind of thing, we have our extended domain that goes from this side towards the public health side and towards the step-down rehabilitation side. How? It is through our extensive what we call system that incorporates in-hospital and pre-hospital service. Yeah, so that's EMTS. It has the pre-hospital component, it has the in-hospital component, and during pandemic, it extends its services outward and inward. Okay. Now, when we tell about pushing the boundaries, the agent of change, then there are a few steps that you have to understand. That you need to have some vision. What do you want to do? Your goal. You need to have the skills, the incentive of why you want to do it, the resources to do something, and what we call an executable action plan. Then you can come about to a change. And in our service, we must understand that in our service, these agents of change is there within our organization. How do we look at it? First, we have a solid organizational structure. There is a head of service, head of state, head of department, consultants, specialists, medical officers, middle level managers, medical housemen, and also 29, 17, 19. Yeah. And then within our organization, we have our resource matrix. That means people who we acknowledge as teachers. These are contohnya, if you want to learn critical care, you go to see Adik Osman or Hada or Sheikh Farid, all these things, yeah, ultrasounds and all that. If you want to learn about trauma, you go through Shah Jahan and his team. If you learn about pre-hospital care, yes, you come through the team in pre-hospital care. If you want to learn about disaster, you have the resources like Dato' Alwi, Kairi, and also Fatahul. And among all these resources, there are some that we can take them and provide us guidance in terms of mentorship. Yeah. So not all resource metrics will be utilized, but some resource metrics that we feel is easier to communicate to or attach to will become our mentors. Yeah. And the resource metrics provides us accessibility to them and knowledge from them. The mentors provide us guidance and motivation to move forward. Yeah. So it's not enough just to have vision, skills, incentive, resource, and action plan. Because if you have that, you are only but one person. But if you link that to the whole organization, to the whole fraternity of EMTS, then you are having a catalyst or agents for change. Yeah. So this is what we are left behind from the legacy of Dato' Abu and Dr. Sabaria. Yeah. So from their legacy, it has expanded to more resource metrics, more opportunity to get guidance and mentorship, and a very firm organizational structure. Now, how do we address the increasing demands related to a pandemic? Remember, you have got ideas, you have got solution, you have got organization to back you up. So then you have to translate all these strategies and ideas into something that is called actionable or operationalization. So kat sini, then you have come to strategic planning, coordination of logistics, contingency planning, and resilience. Now, why I put this one kat belakang ni? Because pada hujung harinya, you may have a plan that on paper it works, and in a scale it works, but when the scale grows, expands, it might not work. So therefore, it's always nice to have a contingency plan of plan A, a plan B, and always check and balance the plan A and when to turn to plan B. Yeah. So prepare and be ready, detect, protect, and treat, goal-oriented, innovate, and learn. Yeah. So innovate and learn is something that is important, but not easy to practice. Okay. Now, let's see how we push the boundaries in managing COVID-19 pandemic in our services. So it starts as simple as in December, all of us start a screening center. Our screening center can start this small, a corner with a tent. It may be expanded to a proper tent. expanded to a barrier kind of structure, and later on a whole complex for screening. Yeah, so it starts from there. What is the idea? What is the foundation? I need to screen. I need to prepare and be ready, detect and protect. So I set up a screening center. And as the plan A, plan B, plan C, adapt and expand. Yeah. So we go another example. When the second phase come in, you need to divide hospital service. A hospital that is a COVID hospital and a hospital that is hybrid or non-COVID hospital. So then what will happen? That's, for example, if your hospital change to a COVID hospital, then you come up with a plan where this service within the hospital will start to expand and occupy everything as the core service. So then the emergency fraternity then come into areas for decanting, changing of this, and then looking at how patient will come more to ED as all these services start to reduce in the number. Okay. Now, dan jangan sakit hati ya. Memang alarm ni is annoying. Tapi kalau saya nak off alarm ni, saya kena tutup slide ni. Ya. Okay. Right. Then, bila kita ada decanting and all the service expansion, then you akan nampak ya, you ada inter-facility transfer banyak, ambulance diversion banyak, shift service to another facility, and you have to have selective stay. So even the emergency department also shrink and expand. Ya. So, bila kita dah nampak benda tu, dah change, then we start, because we in emergency fraternity have to think what if. So therefore, the next step is preparation for the disaster or crisis to come. So what if we cannot contain? Then as early since January lagi, in January 2020, the whole emergency fraternity actually start to look at the wave expansion. Yeah. So what you see is being implemented now was something that has been mooted since January 2020 lagi. Yeah. Where phase 1, you maximize all MOH facility. Phase 2, you use other government facility. And phase 3, you start to use all the private facilities, rent private facilities, and then you start to look at insurance utilization. Even the same thing about transport service. Transport service also expands and also look into how we can further enhance and push the boundaries of our traditional ambulance service. Yeah. But then, as the pandemic progress, what happens? Somewhere along in February, in March, in April, we were quite okay. We were a bit calm, although we have our second wave at that time, but we are compared to other countries, we are quite fortunate. We are calm still. So during that calm, we start to see people, countries locking down their borders. So locking down borders means that you start to bawa balik your people. So then the EMTS is involved in humanitarian repatriation service, and we look at how do we contain this external threat. Again, bukan benda-benda yang janggal for us, it's just part of our education process masa kita buat masters. Betul tak? Your CVRN training, your disaster training. So you nampak how kita bawa patients dari kita punya citizen daripada luar negara, naik flight, pergi ke screening, decontamination, pergi kat quarantine centers, and at the end of the day kalau diorang perlu masuk ke hospital if they tend to become positive. Yeah. Right. But as the scope and the services within the pandemic, you need to contain more, you need to set up more quarantine centers, you need to do many other things. The emergency department became quite static, but outside the pre-hospital environment, it became hectic. So then our arm in the pre-hospital care start to expand in the terms where the role now look at how we can support our colleagues in public health to transport patients in a more efficient manner to quarantine centers and also to hospitals. There we start to do field triaging methods and all that. There we start to have mass transport system. How do we mobilize massive, huge ambulance fleets? Yeah, and then how do we prepare ourselves to support services in lockdown areas, MCO areas? And at the end of the day, think about flying patients between states. Yeah. So dekat situ pun kita start to push the boundaries. Yeah. Initially one-to-one, masa kita buat drill pandemic, it's just about bawa patient ke dalam tu. Yeah. But right now kita nampak dia lebih daripada itu. Yeah. So ini awal-awal dulu masa kita start bus. Yeah. Bus kosong, tak ada oxygen because at that time we were dealing with Cat 1, Cat 2. And in this is Masjid Sri Petaling. Yeah. So when they start to queue, how we set up a system so that we don't leave behind positive cases and infect others. Yeah, this was our briefing session dengan bomber to see if we need to do isoflight flights. Yeah, at that time kita have very limited knowledge and thus kita guna a lot of protective barriers dalam kita punya transport. Yang ini macam mana masa awal-awal MCO dekat Masjid India dahulu kita work with them and then kita set up kita punya what we call field triaging areas. Yeah. And ini is how when COVID hospital becomes receive more patient and we activate more decontamination service. Yeah, right. So then kita pergi kepada the next step. As more facilities are being opened up, we need to expand more than just a single COVID hospital. So then we need to see that in certain areas, state alone is not enough. So you need to combine several states. So then here is where we go to the next step in crisis management. We call a regionalization of bed utilization. So here is where we learn how to manage our logistics better, manage our beds better, putting our patients into what we call designated areas better. Yeah. So again, kita guna balik kita punya knowledge on emergency medicine. That means we are good at sorting out patients, we are good at identifying clinical symptoms, and we are good in getting the right patient to the right center. We are good in terms of 90% of the time it will be correct, and we are prepared for the 10% of the time where there is an error due to multiple reasons. Yeah. So here we start to embark into a unified command center. Yeah. Like the unified command center, it goes into planning, it goes into ambulance service, it goes into bed management, and then it integrates to various other services. Yeah. So in a smaller scale, like many of our colleagues right now have in their states, the unified command center is headed by the head of state, the head of health department in the state, and then it ties itself with many subject matter experts, mainly the head of services of multiple discipline, ICU, emergency, infectious disease, internal medicine, pediatrics, obstetrics, and nephrology. And then it goes with many liaisons of interagency, and then it embarks itself into multiple other hospitals. Yeah? So that is preparing the next evolution or the next phase in our pandemic management. Yeah. Then we must always remember and acknowledge that we are clinicians. We are not administrators. So when the going gets tough, we fall back to increasing and adapting our skills to the various ways. Yeah. So for example, how do we resuscitate COVID-19 patient in this field hospital setting? How do we use all this equipment and manage the fine skills that we have? Yeah. How do we bring about triaging pneumonia patient, detecting pneumonia patient in the field, sending pneumonia patient to COVID hospitals, and sending other patients to low-risk quarantine centers? How do we transport critically ill patients through flight and to many other things? Yeah. Not only that, not only we adapt our clinical pathway in clinical skills, we also adapt and adopt clinical pathways with other specialties. Yeah, for example, when we have low risk quarantine center and we had the surge of about steady state of about 1,000 to 2,000 patients, so we can open up PKRC. How does PKRC evolve with other facilities, hospitals, quarantine centers, and all that? So we start to do a lot of other things. Yeah. So this is nice. I had the opportunity to go to Sabah, and in Sabah they managed their punya COVID in a different way when they had their surge. Yeah, so they are very adamant and very true to the concept that triage before going into a facility. So they started what we call the staging concept, the staging area concept. Yeah, so looking and learning from them, staging area concept, learning with them on how to improve staging area concept, learning with them on the limitations of staging area concept. When my Emts was open, so we adopted and adapted what they have and use it within. Yeah. So how we have an ambulance reception area, how we triage the patient so that different patient within the complex go to the right hall. Yeah. So dalam bab ni dia menarik lah. So we start something like a registration, vital sign, quick clocking, lung ultrasound station, waiting area, and transport. Yeah. So the whole complex of service. Yeah. But it never stopped there, because why? When you push boundaries, you must always be analytical, you must always look back, you must always reflect. Yeah. Again, the reflective learning behavior of an emergency physician. So you do multiple PDSA cycles. Imagine at one time, we were only going to accept Cat 1 to 3. So started by having a process that only filters Cat 1 and Cat 2. Cat 1, Cat 2, high risk, low risk. To a process that now trying to look actively for Cat 3 so that we start to open up pneumonia halls. And then later on, a process that actively manage Cat 4, oxygen halls. Yeah. So how does this change come about within 3 months? All it comes about, you kena buat benda ni. The multiple PDSA cycle. Yeah. That means you must always be able to look forward, reflect, adapt, improve, move forward again. Yeah. So look forward, learn, adapt, improve, and move forward again. But we didn't stop there, because later on through the pandemic, initially you nampak, okay, saya tak cukup katil, saya tak cukup ICU, now saya tak cukup oksigen, now saya tak cukup katil untuk high risk group. So we still continue pushing the boundaries and looking at other areas. Yeah? For example, here we notice that at certain point of the pandemic, you were going to bound to have maternal mortalities. So how do you adopt and adapt and prevent maternal mortalities? Sebab bayangkan maternal mortalities dengan pakar-pakar kecemasan kena tarik, betul tak? So we want to prevent that one. So what we do? We open up a maternity hall dekat Lori Center. Maternity hall in Lori Center. Something that people never dream about, something people never thought is possible, but now we have done it. Yeah. So kita orang ambil sampai 28 minggu, and there are factors right now pushing for us to do up to 32 minggu, tapi tunggu dulu, sabar dulu, because we need to do some more PDSA cycle. We need to learn some more about the 28 weeks. So how do we go about that? By observing the system, understanding the problem, ask the right questions, but always answer with others. Something in this pandemic that really teach us is how to not come in and behave in a taking over manner, but come in and say, how can I assist you? How to come in and not behave as though you are the best, but at the end of the day, ask the right questions and answer all the questions with other people. Yeah. Because kita akan masuk kepada domain yang bukan kita punya. Kita akan masuk kepada teritori yang kita memang takkan faham. But pada hujung hari, if we combine our skill set, we combine our knowledge with that of our colleague from other disciplines, then you're actually pushing your boundaries into the gray area. Yeah. So this is an example of how we change, accept stable pregnant ladies and accept cat-free pregnant patients, and later on send for home quarantine cat-free pregnant patients that we have, triage, manage, and teach them on how to take care of themselves. Yeah. So, how the pandemic affects EMTS? Actually, it builds us to become better. Yeah. Because at the end of the day, kalau kita pergi kepada reflective learning process, ya, dan tidak hanya static kepada the knowledge that we know, and tidak merasakan that we know everything, then we know that the EMTS can contribute by providing a backbone in filling the gaps for community. When you say you want to become a backbone, that means you must be steady about what you know as your core knowledge. When you want to fill gaps for community, you must be positive in the way how you want to learn from each other. Yeah. The second one, it is a chance for us to understand our resilience. Yeah. Many people say the same thing, that during crisis, during pandemic, you really know the true nature of your colleague and you know their strength and weakness. Yeah. And then certain people, they behave in different manner when they handle crisis. Yeah. Now, a chance to improve our base of knowledge. Right now is the best time for us as EMTS to sit down together and look back again on what is our core knowledge. There are certain things that was not imparted to us as our core knowledge, but here's where we need to sit together with our education colleagues and see whether this part of the learning, this part of the experience that we had during COVID, can it become and translated to something that is core that every one of us will now have to undergo, learn, and become our competency. Yeah. So here's where kita kata prioritize our education, professional development, mature professional association, and then transformative skill sets and experience. Yeah. So in a conclusion, again, yeah, sky is never the limit. It's just our mind and our attitude puts us as the limit. Yeah. A positive learning attitude coupled with good ideas and solid organizational structure actually takes us very far. Yeah. So communicating experience and knowledge, sharing knowledge and experience, producing more subject matter experts in different topics, reliable, trustworthy hands and experience, on par with international community and good international networking. So, simple je kan? Pushing the boundaries. So, saya rasa I spend more time to answer question rather than give you all too many theoretical listing. So, free to ask question, free to challenge experience. Yeah, pada hujung hari, we are all students of learning. Yeah. So, back to you, Chairperson.
Thank you so much, Dr. Sarah. So guys, any questions? There is one question from Dr. Hushairi. Excellent thought, Dr. Sarah. Excellent approach. I am even more convinced of our EMTS strengths, truly at par with international standards. I've always suspected this kind of strategy, thinking, and planning behind the COVID-19 response. Unfortunately, not visible enough, unappreciated by the public. One question: did you have to upscale the size of mid-level management, and how did or do you keep their moral level high for the long run?
Okay, so dia ada tiga kita panggil landmark milestone dalam kita punya EMTS COVID management. The first landmark milestone is masa kita awal-awal dulu. That means something sebelum bulan Oktober 2020. Before bulan Oktober 2020, we were each on our own. Each of us manage our own hospital, our own domain. Ya. At that time kita tak ada banyak pertambahan. More pertambahan selalunya datang in term of assistance of human resource kepada ward. Not so much dekat emergency. But then what emergency do is kita buat networking link dengan others. Ya. So kita banyak bercakap dengan orang. Bayangkan orang yang buruk perangai macam saya pun kena start bercakap dengan orang. So that is something you learn. Okay. Lepas bulan 10, then they felt that we can contribute more. So therefore KKM embarked into UCC, Unified Command Center. So for Klang Valley, it becomes regional ataupun zone, central zone. Yeah, it was KL, Selangor and Putrajaya. Yeah. So at a region level, you are expected to manage more, but you are given very limited manpower tambahan. Yeah. So banyak benda saya buat tanpa mengambil logistik yang besar. The reason is simple. We were moving in an upward trend, so you have to capitalize manpower to hospital. So bayangkan kalau kita keluar ramai-ramai daripada hospital, what will happen to our emergency department? What will happen to our hospital service? Yeah? So dalam bab tu, saya kedekut. Saya kedekut bukannya sebab saya ego. It's just that kita kedekut dan kita rasa sayang nak tarik orang keluar pada hospital. Yeah, so we get into the system of rotation. So here's where kita go to head of service and say, can you give me pakar in rotation? That means you lose one pakar for 1 week, I gain one pakar for 1 week, but I gain it in a what we call constant manner. Yeah. Then the third landmark is masa bulan baru ni, bulan 7 tu, where they change the central region to a Greater Klang Valley Task Force, where they bring in everyone inside the task force. So 3 different landmark. Yeah. So sekarang dengan task force kita akan nampak bahawa the logistic, the planning, the whole command center becomes a huge thing. Yeah. But kita juga nampak where kita ada opportunity to analyze, is bigger, more people involved better, or bigger, more people involved makes the learning curve slower. So dia adalah tu. So now pada part 2, how do you keep people punya moral high? Well, itu soalan yang buruk nak tanya saya ya. Saya berkasih sayang dengan orang. Well, actually moral ada 2. Ya. Satu is motivation. Motivation comes in 2 things. Whether it's extrinsic, you get something out of it, or intrinsic, you become a better person. So usually saya perangai buruk saya ni lebih kepada nak membantu orang dalam intrinsic. Yeah? You either like me or you don't like me. If you like me, sometimes you can follow me. Hopefully we can learn and improve ourselves better. Yeah? So I guess dia betul-betul bergantung kepada manusia jenis macam mana tu. Yeah? So most of the time my team akan cakap bahawa we learn from 0 to 10, but we cannot stop at 10. We now have to push and learn 50 other things. Yeah. So itu jawapan saya panjang ya. Sorry.
Thank you, Doctor. There's another question from Dr. Kevin. What are the pitfalls, mistakes we should avoid or watch out when we try to expand the boundaries?
Okay. So one of the few things, the lessons that we should learn. We must reflect on what happened in our emergency department when we start to open, but then kita terlupa that the logistic also kena membesar dengan kita punya opening. Yeah? For example, kita absorb, become span, kita become absorptive capacity, kita absorb patient banyak-banyak sampai nak berjalan dalam resus kena langkah patient. And then we start to ventilate 5 or triple of our usual patients. Yeah? So at that time, kita nampak is good, we open up our doors, but we sometimes kita get trapped into what we call this vicious cycle of our zone. Nampak tak? Vicious cycle of our zone means that you nampak you punya system, you nampak you punya processes, but then you tak nampak jalan keluar pada proses tersebut. Yeah? So many emergency department terperangkap dalam that one. Yeah? Dia nampak yang dia perlu expand, dia expand. Dia perlu proses, dia proseskan. But then dia terlupa nak tengok dia perlu ada jalan keluar. Ya, so kita terperangkap about 1 week dalam that part. Ya, kita expand, tak ada jalan keluar, patient kita mati, kita buka maternity pula dalam ED. Ya, so here is where kita actually some of the learning points. Bila kita expand, we must always have someone outside that looks and then tell us stop sekejap. Ya, throughout kita jaga emergency unit dekat MAIP ni, it goes from 10,000 to 6,000 to 3,000 to 5,000 again. Kita orang pull the plug to stop work 3 kali. The reason was that we found ourselves trapped dekat dalam our own processes and we could not find our way out. Yeah. So pitfall nombor 1, jangan buat. SEP, kita memang resilient, kita memang ada ability to expand, to adapt, but then you must always have the ability and the humility to say stop, take 1 step back so that you can move 2 step forward. Okay? So that is the major thing lah ya, yang kalau saya boleh betulkan pada diri saya nak betulkan yang tu.
Dr. Sarah, one more question. How do you communicate with all the staffs? How do you keep them updated with all the new changes and things keep on changing with a huge number of staffs? How do you keep them all updated?
I think dia sama. One thing is that you kena divide you punya middle level. Yeah? So middle level play a huge role. Remember, saya bukan people person, betul tak? But then my middle level must be friendly and people person. So they are the one yang banyak akan ensure that staff gets orientated. Kalau you EP, you datang ke MAIP, you tak jumpa saya. You jumpa Ong Shufen ke, you jumpa Fariza ke, Sheikh ke. These friendly faces. Friendly faces akan bawa you. Yeah? So friendly faces akan bawa, and then these friendly faces are the one yang akan orientate the staff. Yeah? Occasionally you become the devil lah. You tembak lah orang kalau perlu tembak. Yeah? So communicating, you kena banyak buat sit rep. Yeah? Now sit rep is something yang kita selalu take for granted. Sit rep is actually once a week kita panggil semua orang, kita hello, bukannya apa pun. Yeah? It's just a situation report. How are you? What's new thing you nak? Any new ideas? Yeah? So kalau any one of you pernah duduk dalam sit rep dengan saya, it's actually kita tunjuk what is now. Kita allow people to tell what is day, and then pada hujung hari we come up what is tomorrow. Yeah, so that's it, right? Yeah, what is now, how are you, what is tomorrow. Once you dah ada sit rep, then you datang dengan communication. So majority of us buat WhatsApp, betul tak? So then you kena learn how to buat announcement melalui WhatsApp. That means tarikh, tajuk, daripada siapa, pasal apa, isi dia, and then pukul berapa, waktu mana. Yeah? So then you blast that WhatsApp. Yeah? So macam-macam lah. Kalau you ada sistem how you make your communication through WhatsApp betul, then orang boleh, it's easy for you to identify fake advisories and fake WhatsApp. Yeah? So that's communication.
Any more questions from the floor? Dr. Sarah, in the terms of pushing boundaries, how do we plan ahead, like to face the future challenges without and not entrenched in the response of the current trend? Like something that has not happened yet, how do we plan ahead?
So dia actually kan, kalau you all ada satu benda yang sedap nak baca, masa whenever there is something going on, a big thing going on, macam masa benda-benda Ebola dulu, Wuhan masa dia awal-awal dulu, there is this thing called the medical intelligence gathering. Yeah? So kalau kita akan kata the person kat dalam WhatsApp group kita yang paling nosy, yang paling noisy, yang sentiasa tembak semua macam-macam benda dia korek pada internet dia bagi kat kita, right? So that is actually part of medical intelligence. Yeah? That means you have people on the ground that actually get information, talk to others, communicate, then you faham, oh, there is something tengah brewing, ada angin tengah tiup. Then from that angin tengah tiup, you start to tengok how that angin actually akan sampai kat saya and affect us. Yeah, so that's how kita orang mula-mula come up dengan plan on how to change hospital Sungai Buloh and the whole complex near area Sungai Buloh to become a full COVID facility. Yeah, so it start like that. Again, if you have a good idea but don't have the organization structure to support you, then you pun sangkut. Yeah. So dalam bab ni kan, certain EP, especially orang macam saya, kita very thankful kepada kita punya senior, for having that organization, and again resource persons that we can go to, and again mentors that we can lean on. So organizational structure, jangan jadi kerusumbang dan jangan sekali-kali angkuh dan bodoh sombong.
Dr. Sarah, there is a message from our floor. How can we open the eyes of our supporting staffs to push boundaries together?
Well, supporting staff, they actually want to have the ability to do something new, to understand why they do. Yeah. One of my biggest mistake was that I never know how to communicate on why I do something that I do. Yeah. So that landed me into a lot of trouble. So staff actually, they are with you if you can tell them why we do it, why this thing is important for them, how this thing affects them, their family, their community, and this thing. Pada hujung hari, you find that Malaysians, kita punya staff ni, walau macam mana diorang kasar pun, they are actually very patriotic. Yeah? And if something hits them near home, they are always with you. Yeah, if they feel that you are able to do something and they are able to contribute something that protects their family. Yeah, so itu satu benda lah. Our staff actually is like that. Yeah, they cannot understand. You must take time to make them understand.
Dr. Sarah, any other questions from the floor? Okay, we have 3 more minutes. Dr. Sarah, have anything more to add on?
Nothing. But later on, maybe people like Sheikh Farid, Shairi, Prof. Ismail, later on, I hope that through this pandemic experience, perhaps kita punya curriculum dalam EMTS akan include this kind of what we call critical thinking and disaster management punya thing kat dalam kita punya tu ya.
Okay, thank you so much, Dr. Sarah, for the time you allocated for us in your busy schedule. And thank you also for sharing your journey with us and showing the importance of the teamwork. Thank you so much.
All right. Thank you. Thank you.
Okay, we are ahead 2 minutes. Okay, we'll take a break about 2 to 3 minutes.
Yeah.
Good morning, Dato'.
Hi, good morning.
Hi, so our last speaker today is the person who will always be able to deliver an outstanding speech and full of motivations. So we welcome Prof. Dr. Sri Dr. Abu Hassan. He's the founder and father of Emergency Medicine and Trauma Service Malaysia, currently the president of Malaysian Society of Traumatology and Emergency Medicine (MASTEM). He was the head of Emergency Department HKL from 1992 to 2017 till he retired. But till now, he's still been serving emergency medicines. He holds many posts as visiting consultants and also visiting professors to universities. So let's welcome him to talk on leadership in times of crisis. The floor is yours.
Hi, yeah, Bismillahirrahmanirrahim. Assalamualaikum and very good morning. Thank you very much, every one of you, and Changinta especially for inviting me to speak. I just want to put things in correct perspective. How many people am I addressing this lecture to?
So that currently there is 63 of
63,
us. It's
okay.
involving our lecturers, master students, and also service animals.
All right, fine. Thank you very much. Okay. Yeah, I was given a topic entitled Leadership in Times of Crisis. And that's the topic that I will be discussing, and I have about 45 minutes. Yeah, we'll try and make it about half an hour, and then we can have a discussion also. Anyway, hopefully I can manage the time. All right, so I'll put the slide on now. I hope we can work. Okay. All right, can you see my slide? Can you all see my slide?
Not yet, Dato'.
Yes? Not yet, huh? Just a minute.
Yes, Dato'. This is the critical
good.
thinking.
All right. Fine. Okay, so the topic, as I said, I've been given leadership in times of crisis. Thank you for the introduction. Yeah, I'm still actively working. And okay, so leadership in crisis, in times of crisis, a very interesting topic, and is very timely. And obviously, I will touch a little on the issue about the pandemic, COVID-19. But anyway, let's just go around to understand the concept of leadership and crisis. So these are the lecture component. I'll talk a bit about definition and terminology. We'll touch a bit on types of leadership, types of crisis, leadership personality, leadership in COVID-19 pandemic. And I just will go through a little bit of how to develop great leadership in crisis, and summary and conclusion. Now you will probably will expect this really will be a lot of theory and a lot of philosophy. And I think you need to know that too. Unfortunately, we don't have the opportunity to do a bit of like simulation or otherwise some hands-on and practical. Now, let's just start by some definition. Leader is a person who leads or command a group, organization, community, or even a country. And I think you know now that in this country, we have a little bit of leadership crisis right now. Obviously, it's a person who rallies people or followers to move forward to certain direction. It can be the right direction or the wrong direction. And this person will motivate to manage certain tasks and responsibility and to direct to a successful journey, hopefully, and to achieve certain agenda and to fulfill vision and to make certain mission into reality. And in a way, if you look at all this composition of the leadership responsibility and characteristic, is really quite wide and quite huge. Now, just a little bit on some, what shall we say, semantic or some definition again. Now, what is leader and what's leadership? Now, the leader is a visionary person who direct and motivate and also implement his or organizational task responsibility agenda. While leadership is a continuous process. It's a process which centered into interactions, a lot of interaction between leaders, followers, and which determine the success of the leader's mission. Basically, a leader carry a vision, carry a mission. Later on, I will just touch a little bit on what's a leader and what's manager. Now, basically, the word mission, vision, direction, this motivation, these are all the characteristics of leader. And of course, to implement the process of doing it is the leadership. Now, just put a few more definitions for us to understand the perspective or looking at leadership at different angle and different view. Now, leadership is a trust. What we call leadership in Islamic principle is a mandate, tanggungjawab, and really we cannot just say you're a leader, but without responsibility. And in a stronger word, in Islamic perspective, it's called amanah. It's actually, it's been imposed upon you with responsibility. Now, later on, I'll touch again on this quotation by Peter Drucker. Lifting a person's vision to a higher side, raising a person's performance to a higher standard, and building a person's personality beyond its normal limitation. And this is a very interesting quotation by Peter Drucker, which actually, if you're a great leader, you get the best from your follower beyond your followers' capability and capacity. Now, leader, an individual hold a vision, like I said, courageously pursue the vision. And of course, vision, without implementation is no vision at all. So a leader not only having vision in such a way that it resonates to the psyche of the people, and then of course can make them implement the vision and mission. Now, every person is a shepherd of a flock. That means you are actually the leader of the flock and occupies a position of leadership. And another one is leader is a dealer in hope. That means leader, you just have to deal with whatever scenario and situation. Another one, of course, failing organizations are usually over-managed but under-lead. Now, this one, if you understand this word very well, I think what happened in pandemic 19, there's this element. I think the management is there, but the real certain leadership, certain direction, maybe can be improved. We'll talk about it in a while. Okay, and I said to you again, this is something that I like to echo without apology. Leadership is lifting a person's vision to a higher side, raising the person's performance to a higher standard, and building a person's personality beyond its normal limitation. What does that mean? If you just run a department as a head and people just do the mandatory work and just like that, and nothing change and no excitement and nothing to sort of shout about, that's more like a manager. Whereas a leader in an organization, you will do some difference. You will move the department, and the normal mundane staff will be about 30 to 40%, and there'll be 60 to 50% spending time to improve, to move forward. Now, again, some definition. This is about the art of speaking with a view to influence. I mean, if you are a leader, you must have the art of speaking with a view to influence. I'll talk to you all about skill fluence later, but just to remember that influencing is a very important component of leadership. You will lead others if you can influence them. You need not be labeled as a leader, but if you can influence people, then you are a leader. Now, there's a bit more on the concept of leadership qualities. There's 6 leadership qualities. One is competency. Second is communication skill. Third is courage and confidence. Fourth is consistency. Fifth is conscience, compass, and integrity. 6 is caring. Now, I will elaborate a bit more later. I will touch on this perspective, but all these 6 C's are important. Okay, competency. If you are going to be a leader of the emergency department, you have to be very competent, because you see, status is perceived, performance is real. People will look at your performance. Performance in the aspect of competency, performance in the aspect of communication, and so on. Yeah. Okay, now let's talk about crisis. Now, this word crisis has been used in many aspects, but I think today we'll try and confine it to something that relates to health. But you know, crisis is defined as a time of intense difficulty and danger. It can be defined when a difficult or important decision must be made, and can be defined also as a great suffering and confusion, and where there is disruption or breakdown in the usual pattern of functioning. So it is actually, again, quite broad. Now, if you look at the type of crisis we have, we're quite familiar with natural disaster, and you know what technological disaster. Of course, there is a crisis of confrontation. There's a crisis of the act of malevolence, and this is about criminal means or extreme tactics. Of course, there's crisis within organization, workplace, financial economic crisis, political crisis that we have now, family, community, and of course, number 11, major incident, example, health-related crisis, COVID-19 pandemic, and there's also an issue about spiritual and religious. Now, I'm going to talk about the type of leadership now. This is the third component of my lecture. Now, type of leadership is of many types, but I'll pick up these 4 types only. Transformational leadership is actually a leader that do not bother what's happening, but he has, like the parent, like a teacher, who actually, with the intention of changing the followers to a certain personality, behavior, culture, and performance. And we really hope that transformation towards something that is really beneficial to the nation and to the people and to the activity that will be blessed by Almighty God. Of course, there are transformational leaders who can convert people to become anti-vaxxers, can convert people to become gangsters, and there are a lot of transformational leadership that can convert people to think in a certain direction. So that's transformation, and these people are really very focused and very strong in their belief. On the second part, this is called the transactional leadership. Now, transactional leadership is the one that most of us have. We kind of focus on supervision, organization, performance, and we promote compliance, and we do what we call transaction to rewards and punishment. And if you do something, you get. If you don't do something, and you get punishment. And this is what we call the purpose of exchange value of things. Now, transactional leadership is also relevant, but transformational leadership is a stronger person which do not deal with transaction. They just focus on transforming. Now, later we'll get to know this one: positional leader and real leader. What do you mean by positional leader, positional leader, and real leader? Let's look into it. Yeah? Now, the positional leader are those who have been given a position, and this position may not be the right leader, but an individual who has been placed in a leading role without really meritocracy. For example, you are the most senior in the department, and your time has come to head the department, or you are most senior in that area, and the rest of them have died or have retired, and then you took over. Now, that is positional leader. However, positional leader can be converted into real leader. Now, let me describe that philosophy. What they call this status is perceived. So, positional leader, the status is perceived, but the performance is real. So, status is a position where an individual is being elevated to, that will give a perception. Okay, I am the head department. I am the coordinator of this program. I am the head of this unit or whatever, that status. But however, performance, the output and the productivity is the measure of the real status, as it were. So therefore, a real leader is an individual who performs a leading role in whatever situation. While there is natural or positional or elected, selected, or also when not in position, you can still be a real leader, even if you're not the leader of the organization. Now, what makes us a real leader? What are the special qualities? Of course, experience over a period of time, length and breadth of experience, past success, track record, followers convinced by the good track record, relationship, strength of network, contact, circle of friends, resourcefulness, ability to perform, ability and performance speak louder than everything, of course. Multi-talented, creative, innovative. And there's this thing called charming and exciting. I mean, you are a very charming person, exciting person to be with, extremely good company. And these are some of the special qualities, which if you don't have all, if you have some of it, I think you then can learn how to move towards, to get everything, what we call the holistic leadership. Now, failing organizations are usually over-managed but under-lead. We'll understand this a bit more later. Now, again, I talk about position leader, being promoted or assigned into a position, but does not equate to leadership. Position is perceived, but action is felt. And it is not the position that makes the leader, it is the leader that makes the position. Now, there are a lot of theory behind all this, but bear with me. It's quite nice to learn the theory, Now, the characteristic, of course, the character, who they are, the inner person, the innate character. This is very important. What is your value system? And the depth of your character, your charisma. This is something that actually we can develop. We need not be born with a leadership quality. We can develop. Knowledge, I think without doubt, is very important. There are a lot of these people holding position at head department around the country, but knowledge-wise, they are not really respected. Now, there's this thing called intuitive and instinctive. And some of them perform very well without you realizing why they are like that. And this is the extra capabilities, and they are intuitive and instinctive. Now, this called the wisdom. It's something that you can develop after a long time. You cannot get wisdom just by reading a book or something. That over a period of time, sometimes you stumble and fall and you get the wisdom. This is the ability to deal with the intangibles, and you can actually come up with some what we call suggestions or proposal, which is beyond comprehension of others. This is what I call the overriding wisdom. Now, experience, of course, where they have been and what they have done. So when a real leader speaks, people listen. Hopefully, we can achieve that. Now, again, on real leader, what are the critical success factors? Unity of vision. What does that mean? Actually, it means that he or she can convince the team members to have a joint vision, to share their vision. If you look at some of the political party in this country now, there are members who do not share the vision of the leader, and also something. And it's something that we can learn. If you look at all these statements and you can relate to what happened in this country, it's very interesting. It can really touch on what the principle of the leadership. Now, diversity of skill. Yes, of course, we need a lot of people with all the capabilities. People who can write, people who can speak, people who can sing, people who can dance, people who can do all sorts of things. And when they are together, this is what we call the horizontal task distribution with different strength. Classic example is our trauma team. Now, trauma team is horizontal task distribution with a team leader. Now, the team leader will combine all the diversity of skill and to be able to achieve the target. Of course, dedicated to victory, success focus, again, the unity of vision, and raising personal performance to above their potential. This is what Peter Drucker had mentioned just now. And of course, I said to you that we are going to learn a bit about what's the difference between leadership and manager. Now, leadership is about influencing people. Management is about focusing on maintaining daily routine processes which have been established by leadership and the team. And the manager must also have leadership quality, hopefully. But otherwise, he will just stay as manager. And when the time comes for him to lead, he or she will not be able to lead. So managers maintain direction, but usually they are not the changing one. Now leaders move people in new direction. All right, so again, just to summarize the special qualities of leaders: experience, length and breadth, past success track record, relationship, and of course, the ability to perform, and performance speaks louder than everything else, multi-talented, charming, and exciting. Okay. Now, of course, there will be the natural impact of great leaders is the creation of many more leaders. This is something that I always believe. There's no point to be successful alone. If you're successful alone, your leadership is successful is not complete. The natural impact of great leaders is the creation of many more leaders. Now, this should be a deliberate effort that you must know. If you are a leader, you must develop more leaders. And hopefully those leaders become better than you. And it takes a great leader to raise another leader. And the followers can't do it, and neither can the organization. It takes one to know one, to show one, and to grow one. Yeah. All right. So leadership in crisis. A crisis is when most important for leaders to uphold a vital aspect of their role, making positive difference in people's life. And doing this requires leaders to acknowledge the personal and the professional challenges that the employees, the system, the organization, and their loved one experience during crisis. So you must actually have empathy to understand. Now, like I said, leadership presence must be a strong one in every aspect, every interaction, physical. See, our persona, our image is also important to be felt and to be missed and to be wanted. Yeah. And intellectuality, of course, the knowledge and skill, your voice, your intonation, your expressional clarity, emotions and self-control, and your messages, to create some good impression. I like to talk about this quotation, which I always say. Now, self-control is a strength. Calmness is mastery. Don't allow others control the direction of your life. And don't allow your emotion overpower your intelligence. Now, this is very important, which I'm going to touch a little bit more later on emotional intelligence. Now, let's talk about how to develop holistic, robust, resilient personality of a leadership in crisis time. Okay. Now, there is this thing that I said just now about 6 personality of leadership in crisis. Confident, self-assured, self-confident without being arrogant, capable and competent, and there are proper balance in depth and breadth, not superficial. Committed, of course, they have to continue to perform regardless what challenges, and they just cannot give up halfway. Their passion and courage is balanced by the sense of responsibility. And this is important, of course, the sense of self-discipline. And connected. And very important, they value relationship, and they're always what we call people's leadership, and people are willing to interact with them, and they are able to interact at all levels. And of course, communication skill and caring. I think caring and effective leadership is very, very important. To have a strong sense of servanthood, and of course, to be part of the community and also a team player. Now, leadership in crisis management, the quality determines the personal and the organizational effectiveness. Strong leadership brings greater effectiveness. Weak leadership limits effectiveness. In times of trouble, if you cannot cope with one leader, organization have to look for new leadership. Is that what's happening in this country? Well, we'll see about it. During crisis, your leadership ability is being put to test. Leadership is flexibility, creativity, and innovation in crisis intervention. Now, as far as the personality and professional development, these are important. Yeah, you look at your physical self. You have to be robust, quick, fit as well. That's why you have to do exercise, and you have to be a leader who is fast, quick, and you cannot be a slow motion rider. Mentally, you have to be robust and resilient and quick. I can think if you look at some of our leaders, some of them are very sharp, very quick to respond. Their synapse is very quick, but some of them very slow thinker. It takes a while before we can get some wisdom from them. They speak slow, they think slow, and that's not good enough to be a good leader. Now, of course, spiritual, core strength, image, professionalism, the way you dress, the way you walk, the way you talk, interpersonal skill, soft skill, caring is really been felt and been seen. Your behavior, mannerism. I'll talk a bit more on emotional, spiritual quotient in a while. And of course, we already talked about leadership quality. And again, I'll touch about stress immunity. Now, this holistic approach in every aspect of human resource development, which we have to deal with, and all of you are in this process of skill development, knowledge development, but later on you will acquire administrative and management principle. Now, people management, human resource management is very, very important. Resource and financial, of course. Now, I just want to touch a bit on this thing. I like this person, Howard Gardner, Howard Gardner. Now, Howard Gardner talk about multiple intelligence. Now, if you look at this book, Howard Gardner's book, he talk about the different type of intelligence, even for that matter, sound intelligence, spatial intelligence, bodily kinesthetic intelligence, and all that. Let me have a look at, show you this book. This is the book, what we call multiple intelligence. Now, what I like about Howard Gardner's book is about saying this, when we pass an exam, we only have one type of intelligence. Okay, that may be linguistic, that may be logical, mathematical, and so on. But if you look at the other type of intelligence, what do you mean by spatial intelligence? And you can position yourself in the community. And what about naturalists? You understand about the environment they work. What about existential? Existential about iman, about spiritual. And of course, bodily kinesthetic, we talk about how we behave. The bodily kinesthetic, if you look at Mr. Bean, for example, he can send message without even talking. So that's called bodily kinesthetic. But we're going to the specific later. I just want to touch on this one. This is so crucial. Now, if you look at this by Howard Gardner, he doesn't talk about IQ, because IQ is only for you to pass exam. You're very theoretical. You can, write good papers, and you can, of course, come up with a lot of knowledge. But the real strength in successful individual is what we call the emotional and spiritual quotient or intelligence. Now, this is really a very important part of leadership in crisis. Even if you have the knowledge, but if you cannot cope with your emotion, or you cannot maintain manage your stress, then you cannot be effective. So really, emotional, social, or spiritual intelligence defined as being effectively understanding us and others, and relating well with people, adapting and coping, and relating immediate environment surrounding. And this is very important for people to understand, that you are very, shall we say, in control of your emotion. Now, emotional intelligence really is the area of the cognitive ability involving traits, social skill to facilitate interpersonal behavior. Now, intelligence can be broadly defined as the capacity for goal-oriented adaptive behavior. You heard about Howard Gardner, but emotional intelligence is very important, what we call the ability to manage feeling of yourself, manage your expectation, you manage your own capability on managing stress, and of course, you can manage others as well. Now, 5 major skills, which a bit too much for me to discuss, but what we call self-awareness, self-management, social awareness, empathy, and motivation. But just remember, you have to develop your emotional intelligence before you can be a good leader in crisis. Okay, I'm not going to talk about this because it'll take a long, part of my lecture. But developing emotional intelligence is important. After you pass your exam, you must understand this in the process, because this it's not been taught in school or otherwise university. But please keep thinking about how to develop emotional intelligence, because in your brain you have this practical skill, basic educational skill, interpersonal skill, and there's this thing called emotional skill. Yeah? And that you have to develop in order for us to have strong motivation with empathy and feeling for people, of course, maintaining our self-esteem. And with that, we can make good decision, strong commitment, and of course, interpersonal awareness. Now, this actually is part and parcel of what I call the Howard Gardner multiple intelligence. Okay, now let's move on to something, the agenda of what we are now facing. If I don't talk about this, I'm almost sinful. Or don't put your, I mean, even pandemic COVID-19, which to me is very critical. In some parts of Malaysia is what we call the apocalypse now. And in fact, in some of the healthcare organization, I think the emergency department and the ward in Klang Valley and in Selangor is actually towards catastrophe. Like I said, people are dying at the rate of 20 to 30 deaths per day, and they don't have oxygen. And look as though the healthcare system is either collapsing or already collapsed in some places. Now, this is because of high patient mortality and, of course, increasing frontliners' morbidity. Now, even if you're vaccinated now, I think you know about the breakthrough infection. And this is why the number that we see these few days up to about 20,000 or so. And the death have climbed up from 100 plus to now the latest 300 plus deaths per day. And that is really, really almost like catastrophe. And we scored gold medal in COVID world meter of COVID report. Yeah? So not in Olympic, but in COVID. So you see this, and these are all pictures of how a hospital have in a way collapsed. You know, people are just lying on the bed and some on the floor and waiting for oxygen. And then from category 3 become category 4 and category 5. I don't need to bore you over this, and some of you are witness to this already. And if you go to HKL or Klang, you can see. Look at this. This is the resus room in emergency. I've got another picture in the decontamination room in HKL. I know some of you know about this one. Now, this very congested work area with the air loaded with coronavirus, definitely you will breathe it in with a low ceiling, poor circulation, and 80% of the air is recirculated, and definitely we'll be inhaling the COVID. But obviously, the breakthrough infection after vaccination is something you all must remember. We are praying to Almighty God that the vaccine that we receive can manage the Delta and the Lambda variant. However, there are about 5,000 of frontliners who have been vaccinated, who are now being infected. But so far, Alhamdulillah, they're only up to category 2. Now, COVID-19 pandemic impacting global health economy. Well, really, when we can't control the situation, we have to challenge ourselves to control the way we respond. Now, I'm a believer of this, that we should not stop human activity. We should open the mosque. We should let people do economic activity, but we must manage human behavior strongly. Definitely. In learning the new norm, in learning the new behavior, in learning the new order, basically, government must invest on this, on the prevention and people behave. Look at what happened yesterday. People are queuing at the Grand Season Hotel, and really, it was so pathetic. And they are just hugging each other. And where is the management of human behavior? And this is why when people are doing that and they are serving you in the restaurant and they are the guard at the shopping complex and they are holding, the temperature meter and so on and so forth, and they're coughing in front of you. And as you know, Delta and Lambda will be in you. So pandemic COVID-19 threatens human survival, the well-being of human, and dignity and human security. Now, the whole world is facing difficulties in managing major incidents while making effort to reduce the spread of COVID-19. But we in the emergency department, we in the hospital, having dual hazards, or what we call double jeopardy. We actually respond and manage patient, but we also will be a asymptomatic carrier. So managing one and exacerbate another. So, okay, anyway, just to go a bit on leadership in crisis during pandemic COVID-19, this is a bit philosophical. I want to elaborate a little bit more. Now, there are a lot of issues that if you heard what Dr. Sarah was talking about just now, about decision-making in uncertain time. Now, uncertainties is the order of the day. How do we make decisions in the midst of uncertainty? I'll touch on it in a while. Now, to weather the crisis, of course, we have to build network of teams. We have to listen to people. We have to get input from everyone in this country. There are many good experts, experienced people out there, retired or otherwise in corporate world, and the Minister of Health must listen to everyone. That's why we talk about to weather the crisis to be network of teams, organizing via network of teams. Yeah. Now, communicating with people, with stakeholders, with community, understand them is very important. Of course, we have to demonstrate calmness, optimism, this, of course, displaying deliberate calm and bounded optimism. We cannot just be so optimistic. We must actually understand what is be more predictive in terms of intuitive and instinctive. Now we must cultivate compassionate leadership. They must come down to the emergency department. They must go around to see, and they will have the empathy. Unfortunately, I think this is a bit lacking. People go talking in front of the press, and they are talking about numbers, they're talking about all these things, but they really need to understand the people. When people want something because they want to keep afloat, they want to be motivated, I think the leaders must do that. I think that's a lot of lacking in this one. Now, please move on to this. This is the technique and tactic. I'm sure some of you may not follow me, but just later on you can capture these slides and then understand more. Look at this. Number one, decision with speed over precision. Okay, what does that mean? During crisis, there will be a lot what we call the cognitive overload. People just, so many things come into people's mind. Unfortunately, there's incomplete information. And I remember this has been said by the head of an organization. They say, oh, nobody is an expert in COVID-19. Well, that's true, because there's incomplete information. But you have to create the interest, and we have to create priorities, yeah, because interest and priority may clash. Some people, they are interested in buying ventilators, but they are interested in talking about screening, but priorities may not be there. Now, let me say this. In the beginning, you heard the announcement that they are buying 900 ventilators, but is that the priority? Now, you see, when we talk about Sun Tzu in the art of war, in the wartime, you must fight the war at the front. And what does that mean? You must fight the war at the front, and the best victory in war is when there is no fight at all. So I would have believed strongly that if I run the COVID-19 pandemic, I would have bought a lot of test kit and test people everywhere in the concept of FTTIS. Find, trace, test, isolate, and support. But we bought a lot of ventilator. We maybe buy a lot of ventilator, but we don't buy enough oxygen. People are dying in the emergency department without oxygen. Now, precisely why we talk about emotion and anxiety run high. People will be shouting at each other and so on. So the leader must have the speed to process little and whatever little information you have, and determine action with conviction. But you have to engage many people to understand what's best for the country. That's why I remember define priorities, to identify, communicate those priorities. As I was saying to you, in pandemic at early stage, remember, we only test those with gejala, whereas we now find out that 80% of the transmitters or transmission is done by asymptomatic transmitter. So we miss the whole thing. So we blame the people from the public while they are queuing to be tested, but the nurse told them, oh, tidak ada gejala, boleh balik. So when you create all this scenario, now that's why we have climbed up to this number. And of course, again, about the Sabah election and when people are relaxing, and that's it. No? So define priorities. Isolation, testing should be the first part of COVID-19 intervention. Mass testing, that's exactly what Singapore did. But of course, now that because of the mutation, a lot of people now have to review to step up their testing which is sensitive to the mutant, the variant of concern. Yeah? Now, make smart trade-off. What does that mean? You see, there's something between urgent and important. If you focus only on important, but you don't realize how urgent things are. So actually, between urgent and important, you may want to do something which is urgent. Now, the second one, between survival and success. Actually, like now, survival, people are dying because of lack of economy and so on and so forth. So think about it. If you want to be successful in COVID management, but people are dying because they commit suicide and they have no money. So this is kind of a smart trade-off. Interestingly, if you think about it, if in your quiet hours later, you think, are we really doing a good, what we call balance between survival and success? We want to be successful in combating COVID-19, but we don't manage the survival of people. Now, between urgent and important, as I said, and as I said, the best leaders use priorities as their main criteria. Now, determine the decision makers. Now, this is important. If you are the boss of the organization, you must empower more reliable managers to run. You cannot do everything your own. And let them make decisions where possible so that they're buying in. They want to do. In fact, some of the head of department in some of the hospitals, they're totally fed up because they said that they are not part of the decision making and they're just being asked to do this and the other. And there were a lot of crises where decisions were made from the top and people down there do not know anything about it. They want to close, let's say, Ampang Hospital for COVID. Where will be the non-COVID patient going to go? And HKL, the same thing. I was talking to some of them, and they have to pay 17 million to send all the non-COVID to the private hospital. Now that's finally okay, but why is it done at the rush? So this is an example of if you gather everybody together, the director of hospital discuss and how to manage a non-COVID patient and so on. Death is death by COVID or by heart disease is still death. Anyway, what do you mean by embrace action? Now, at this time, you cannot go on punitive mode. People make mistakes. Some people make wrong decisions, but during crisis time, it should be non-punitive for crisis. In fact, there are some of these young doctors being punished for making statement, and then one of the pakar in HKL been asked to write a show cause letter and so on and so forth. All these are really just not on. During crisis, a lot of people have got, like I said, emotion run high, anxiety and so on. So let them ventilate. It doesn't, after all, to me, when people punish one or another, that is really not good leadership. Embrace action, non-punitive during crisis for mistake, because failure and refuse to act bring worse result than actually making mistake. Now, what we call adapt boldly, sorry, that's wrong spelling, B-O-L-D, boldly. What do you mean by that? Strong, effective leader can get ahead of changing. So things are changing, but you have to adapt some decision boldly, to admit inadequacy, and to get assistance from others. This is something which is not done very well presently. And they are fixated with their decision, but you have to change when needed. Now, reliably delivered. Now, take personal ownership in crisis, align with the team to focus on the culture of accountability. Engage on impact. We should see result. Okay, we've got lockdown, we've got emergency ordinance, we've got SOP, we've got everything. Are we engaged with impact? The impact is still not there. So how are we going to get buying in? We've done everything that we could, but the number of that is still 300 plus. See, when I make all these comments, I'm talking about maybe we have not engaged with impact. We are doing the process of all the process of preventing, but the impact is still not positive. Okay. Anyway, I'm coming to the end of my lecture, I think, but I almost just ran out of time. Yeah. Okay, so the ultimate of measure of person is not when he stands in the moment of comfort and glory and convenience, but when he stands at the time of challenges and controversies. This is by Martin Luther King. Okay, just for summary and conclusion, I just have a few more slides to talk about. I think I have 1 more minute, yeah? Okay, first, there's something called leadership reinvention. Every one of you must understand, after passing an exam with a specialist, you are not yet there, you know? You have to reinvent yourself. From a senior medical officer, from a master's student, you have to go on the mode of to reinvent yourself to be a leader in a group, what you call yourself as a specialist. Then there's this thing called leadership with skillfluence and skill to influence. And of course, again, on emotional intelligence and stress immunity. Now, leadership reinvention. Now, I just tell you about this one. A great white shark needs to continue to swim in order to get oxygen and to continue living. So you have to do the same. In fact, they said about the eagle, at the time when the beak becomes so pointed, they have to sharpen it and to be able to hunt again. Yeah. So the lesson for leaders who feel that they have made it, once they have reached to a certain position, they have got their award, they have got this puji-pujian, they've got everything. So they are resting on their laurels, but they don't realize that actually you have to reinvent yourself, to keep moving and to move on. You have to understand to stay relevant, to stay evergreen. Otherwise, if you don't stay relevant and don't stay evergreen, you will be at risk of fading away into the abyss of mediocrity. Now, read this and try and understand what's happening in this country now. Okay, transformation and leadership reinvention is deliberate effort. And to sustain effective leadership role in order not to be overwhelmed by the comfort of status quo. This is my quotation to tell everyone that you have to continue to improve yourself, to learn to reinvent yourself. Okay, now it is not the strongest of the species that survive, nor the most intelligent that survive. It is one that is most adaptable to change, so transform. Yeah? And if you cannot change the direction of the wind, then you have to adjust your sail to move on. Now, let's talk about leadership with an influencing skill. Now, you must be able to influence people with purpose, and the art of influencing, or the skill of influence, or what we call skillfluence. Eh? Now, this is very interesting. I wish I could talk about this deeper, you know. But anyway, there's something called this practical skill to influence. You use your hands, your head, and your heart. Direct method, the head, logical appeal, logical persuasion. By hand, cooperative appeal, working together, join hand, work as a team. Now, of course, the indirect approach is the heart, the emotional appeal, the connection by emotion, feeling, and sense and pride. Now, the 3 ways to influence: logical appeal, emotional appeal, cooperative appeal. Now, think about this later on. You know, we can have another discussion on this one, but there is actually a group work on this one. How to do logical appeal, emotional appeal, and just remember the word skillfluence. Now, look at this, the hands and the head, hand, heart appeal to influence. A child smiling, extending his hand in offer of friendship. Now, every time we try to affect how other people think, behave, or decide, we are trying to influence them. A smile and a handshake, which we can do now, handshake. An attempt to socialize, to form a connection, and to break down barrier. So this is the head, hand, and heart skillfluence. Yeah. Now, educating the mind without educating the heart is no education at all, by Aristotle. Now, the next one is just again on the emotional intelligence, or otherwise stress immunity. We need to have intelligent quotient, emotional quotient, and spiritual quotient. Intelligent quotient is when you pass exam well, you are the A student, you can do computation, you can do skill, you can do language, you can do logic, you can do application. But if you do not have emotional quotient, all this knowledge fail the moment you shout at patient, the moment you shout at each other, the moment you don't come to work, the moment you take EL because you are upset, the moment you are stressful. Now, spiritual quotient is the integrity and the sincerity and the honesty. And this one is guided by your spiritual belief. That's why those who do not have spiritual belief sometimes are not guided by this spiritual quotient, as it were. So we have to develop our stress immunity. Now, stress immunity is about stress inoculation. If you get scolding, if you get battered and people say bad things about you, those are what we call the stress inoculation. Now, resilient stress coping ability is very important. Now, stress inflation is the everyday work that you get challenged by so many things. A regular dose is important for us to develop our strength. Of course, if you're not able to cope with stress inflation, you get depression. And we will try very best. So if you look about the suicidal tendencies right now, these are all because of the no stress immunity and there's no coping mechanism. Now, please understand, among all of you, there are different levels of stress management, but I think all of us must develop stress immunity, the stress coping ability, less risk of depression, eliminate all the suicidal attempt or all the immature action. Okay, now finally, I'm just going to go on to this part that we must develop ability to handle crisis with all the knowledge, and it takes a while before you become experienced. And don't worry, there is a journey. And the last quotation I'm going to give you all is this, the journey, and the journey is as rewarding, as enjoyable, as what we call with good return as the destination. So don't think about the destination only. Enjoy the journey of developing yourself. Finally, the destination is determined by Almighty God. We just can hope to get to the right direction and to work towards it. Thank you very much, and sorry for the long lecture, but I can't help it. There's too much to talk about.
Thank you, Dato'. Is there any question from the floor? We have a question, Dato'. How would you handle how would you handle the situation when the team is tired and hence it's difficult for them to accept the changes and the plans that has been implied?
Okay. So there are three things there. Number one, you said that the element of tired, they are tired, you say, they are exhausted. Okay. And number two is it's a very big crisis and challenge that are needed. And number three, of course, the leadership role. Now, first and foremost, there is what we call the preventive and the intervention. Now, we should not allow exhaustion and tiredness happen. That's the first thing. If you ask me how to manage it, I would say we should prevent it first. As far as possible, human resource management must be done in a manner where exhaustion and tiredness should not happen. But somebody say, oh, there's not enough people. Well, we can make it enough. You have to now mobilize people. And that's why, like now, for example, HKL full of tired people, but maybe we can get people from police. Only now they are bringing the soldiers and so on, and the armed forces. So first, to prevent it from happening. Secondly is to manage it. Now, managing it by many methods, Of course, provide them opportunity to relax and unwind, reduce their stresses, and the leader must be with them, must calm down and be with them. And in fact, sometimes, like I said, you are a very strong motivator. If you are the caring leader, the moment they see you, they will get up and come to you, and you have to have coffee with them and chit chat. Now, this is a very important element. So the intervention, I can talk about it for what I have done over time. Yeah. And like I said, no punitive action, even if they're tired and they have neglected, for example, the nurse who make mistake in not injecting. We should understand if they are tired and they make mistake, it's our fault, because it's about a balance of load and capacity. If the load is overwhelming and the capacity will not be able to handle, definitely we'll get some what we call problem mistakes and so on. So prevent, manage, and of course leadership role.
Thank you, Dato'. Any questions more? Okay, Dato'. Thank you so much for spending the time with us today.
Okay.
Talking on this topic. We really appreciate your time, and I hope this can help all of us to be a better person in leadership, especially these times. Thank you so much, Dato'.
Okay, welcome. Thank you. Thank you for listening.
Bye, Dato'. Team, our colleagues, we will share the QR code This would be our QR code for the CME CPD point. Okay, thank you so much to all that is listening. Any questions or any discussion from the floor? Why Professionalism? Prof Ismail, got anything to say? I see you unmuted.
Well, I thought I want to have a discussion with Dato regarding this whole thing.
Dato
But
is
since
still here. Is Dato is Abdul. Amirul Nasri. Oh, Dato left already. Anything Prof wants to add? Prof Ismail?
Is Dato Abu still around?
No, he left already.
Okay. Okay. Never mind, it's all right. I think there's not much lah. The thing that I was wondering why you see if we are facing with a condition like right now, and we have strategies being put down of doing of the SOPs and doing all of this thing. I think one of the thing that obviously
Prof, you are muted.
Hello, can you hear me?
Yes, now can.
Okay. Hello.
Yeah, now can hear, Prof.
Okay. Okay. Regarding this, the situation that we're facing right now, the pandemic, people see that, right? We have all now MKN and the government has come up with a lot of strategies. Well, almost about the similar strategies all this while, right? SOPs, which basically is not working. Not many people are following SOPs, right? People still sitting close around in the closed compartment, in the same room, whatsoever lah. I think all those things. Now, and the case is climbing up. I'm sure there is someone with some brain in higher up, okay, should basically notice that, hey, things are not working. True or not? Because the case is coming up, the death is coming up. Okay, the case is coming up, I'm not that worried, but the death is coming up, I'm worried. And the Cat 3, Cat 4, Cat 5 is actually still maintaining quite high number. Now, if the strategy is not working, why can't the leader or whoever is in power change the strategies? I think that's the simplest thing. True or not? I mean, we can. I'm sure we have so many brains in this country that really can see and analyze lots of those things, right? And we keep. I mean, just like what Dr. Sarah just now mentioned, we must keep on moving forward and just saying that, okay, we use this strategy and the strategy being used for the last 6-7 months, and but the number of cases is getting bad. So there must be a way on how we should be able to come up with new strategies on how to overcome this kind of thing. And I'm sure there is. If you put people together, if people are really sincere into looking at this thing, there are ways and means how we can get this thing done. That is my opinion on this kind of thing. Just like, I mean, you send your son or you send your daughter to a school. If the result is not improving, and basically every day we hear from the government, oh, our achievement that we have increased our numbers of vaccine. Good. It's just like, okay, my daughter is studying, instead of 2 hours a day, he's studying now 6 hours a day. Good. But at the end of the day, you look at the result of the exam. Hey, my daughter's result is not improving. So don't you think that something is I call it cognitive dissonance in all these things? Something's not working and something is not right. And when something is not right, we need to review, right? And I'm sure that if we really open this thing, or the government can have an open platform, get the suggestion from people from all over, just like what Dr. Abu also has mentioned, be open and getting suggestions from people. There are good suggestions coming up, but why it is not being done? Okay. Even if I mean, every day you see the data of what do you call this, the number of people who died, and Ministry of Health just putting that, okay, 70% of these people has not been vaccinated, 90% of these people has not been vaccinated. What does it mean? To me, it means that, okay, and on the other side, you are basically, people are still screaming, I want to be vaccinated, but I've not got it. I didn't get the opportunity to be vaccinated. So therefore, can't you think that we have to change our strategy of vaccinations? Why you keep on highlighting people, please register and vaccinate, but people who are claiming to get vaccinated are not being given the vaccination. And as a result, we can see that a lot of them who died, or and who are basically in the higher category of 3, 4, 5 are not being vaccinated. And that's what you can see. So this strategy need to be reviewed. And in this situation, relating to our topic on leadership this morning, I think we need to have a good leader who can see this thing and basically come up with a newer strategies. I think that's one of the things. A good leader is someone who can basically not only know how to direct people of doing this and that, but basically have to have a big open mind and basically willing to accept, okay, there are something that we did right and there are something that we could do better. And I think that's the way how we can move along, all right? Because Malaysia has been in this stage for many more months, and people say, oh, this is actually the bad stage, we're going for another few more months, but by September or by July, by July or August we are out. But it seems we are not, all right? India was in this deep shit, right? Sorry to use that word, but they come out. Italy was into the deep shit, something like this. They came out not that long. We are in this deep shit from the time of this PKP3 until now. It's actually quite a long time, and we have not came out. The question is why? And my analysis from this thing is actually about, we are coming out, we are using the same old bullet, the same old strategies, and the strategies is failing. So there must be a way to come and think out of a way how to move forward. And I think it's go back to the leadership, because what we are facing in the ED is basically taking care of all the thing that has been passed through. And I've been telling people from day one, if you want to tackle this disaster, close the tap, because we in ED is actually just like the basin. All the tap water keep on coming out, and we're just collecting, and we got patient, tons of patients coming in. But as long as we don't, selagi kita tak tutup the tap water, the tap, selagi itu air akan keluar. So now we have to have a strategy of how to close that tap. You know, so I'm sure there are ways and doing this thing, but nobody is really going forward and doing this thing or changing this thing, or there is already the tap is already jammed, so we cannot close it. I don't know. That's why I was hoping that Datuk Sri is here so that I can basically have a discussion with him on this thing. I don't know, maybe if anyone wants to comment on that.
Anyone has some opinion, guys? We are in the process of being there, Prof. You guys are already there.
Yeah.
So, Prof,
but because the thing is that why do we want many more people to die? That's the question is, we know that it is not working, we can do something, but we say that, okay, eventually we will reach the saturation point, and basically we will reach the point where things can come down. Yes, it's true. But the question is actually how long more we're going to reach that? Because the answer is nobody knows. But that is actually how long more we're going to reach that. To me, it's again not a big problem. But the problem is actually to reach that point, there will be many 200 to 300 people die every day. So as a responsible person, okay, all of us, do we want to see that thing happen? More people die. I think this is the thing. What we do in ED, I don't think will change much in terms of the outcome, because we are basically getting the last batch of or the last level of people, which is already very bad. but it have to be done away from the forward, way in front, and that's the way how I think we should fight this war.
Okay, Prof, I think all the speakers today actually mentioned what Prof mentioned also, asking for help, open for discussion. Asking
Yeah.
for help or suggestion is never a sign of weakness. Making
Yes.
decision by ourselves may not be the best decision compared to a collaborative decision. So I think this every 4 speakers plus Prof mentioned about this today. So I think that would be our main take-home message, and hopefully
Hopefully, when you all become leaders one day, you will make different decisions.
I'm very sure the topic today, all the discussion today gave us some idea of things that need to be changed, what further things that we can change to make this
Yeah.
leadership in progress.
Check and balance. It's always check and balance. Okay. All right.
Okay, thank you so much, Prof, for your input, and thank you so much, guys, for listening to the topics today. Would like to thank all the speakers that was involved, and all the committee members around here that helped to settle the top topics today. This is the QR code being shared again. We will share again in our group if anyone not able to scan this through. Okay, with that, thank you all for listening, and we'll see you again in other next CMEs.
The QR code is for what? For CME, is it?
CME CPD point, Prof.
CPD points. I see. Okay. All right.
Okay, thank you so much.